Thank you so much, everyone, for coming. We're really hoping that this stems a lot of wonderful discussion. We have a great variety of panel speakers today as well. So we have Al Barfoot, our Deputy Warden, just to welcome everyone and open the event today. And each speaker, we've kind of allotted a few minutes at the end of each of their presentations so they can answer questions. And at the very end of the session, we're hoping to have a panel discussion. So if you have questions that weren't answered after their presentation, we're hoping to get to all of those following everyone's presentation. And we have 2 snack breaks, so we have some food at the back of the room and some beverages as well for everyone. And just let me know, or Scott know, if you guys have any other questions throughout. And thanks so much for coming again.
Thanks very much, Stephanie, for the introduction. Good morning, everyone, and welcome to this very exciting event. Warden Halliday is attending the Federation of Canadian Municipalities Conference in Halifax, so I'm pleased to bring greetings on behalf of Grey County. As Warden, your scripts for greetings are prepared for you, and all you have to do is read them. As a past Warden, you write your own, so here goes. One thing is certain, we are all getting older, and the more choices we have as to what is available, the easier the choices are. This event will raise awareness and understanding about how aging people experience our communities and how they interact with services and spaces and how their health changes their perspective of their environment. There's a great lineup of speakers who will enlighten everyone in health awareness and age-friendly communities. I promised myself that I would not make any jokes about planners, even though I know there are many in the in the audience. Again, welcome to Grey County and have a great day. Thank you. Unfortunately, I can't stay for the day. I've got 2 other events to go to, but as I say, I know the agenda looks really good, so congratulations. Thank you.
Excellent. One more speaker here before we get to our main event. A few little logistical things. Washrooms are just through these doors here to the left. And should there be an emergency, the exit is where you came in. But we'll lead you there should anything come up. So as part of these events, we have a duty to recognize the owners of these lands before we were ever even thought about. And today we are on the traditional territory of the Saugeen Ojibwe Nation, the Chippewas of Nawash, unceded First Nation, and the Chippewas of Saugeen First Nation. They've given us a little blurb here that I'm just going to read to you that helps us understand some of their perspectives and why we acknowledge these traditional lands. We acknowledge them both for recognition and respect of Aboriginal peoples. We want to recognize their presence both in the past and in the present. We want to recognize and respect the essential elements of establishing healthy reciprocal relations between First Nation or with First Nations groups. And we know that these relationships are key to reconciliation. And they've just given us some further thoughts here on why we acknowledge the lands. It's a formal statement that recognizes the unique and enduring relationship that exists between Indigenous peoples and their traditional territories. To recognize the land is an expression of gratitude and appreciation to those whose territory you reside on, and a way of honoring the Aboriginal people who have been living and working on the land from time immemorial. To understand the long-standing history that has brought you to reside on the land, or in this case, for some of you, visit the land here today, and to seek and understand your place within that history. Acknowledging the land is Indigenous protocol, and a land acknowledgement is a reflection process in which you build mindfulness and intention walking into whatever gathering you're having, in this case, the aging event. The acknowledgement of traditional territory. I want to acknowledge the traditional territory of the Anishinaabe Nation, the people of the Three Fires, known as the Ojibwe, the Dawa, and the Potawatomi nations, and give further thanks to the Chippewas of Saugeen and the Chippewas of Nawash, now known as the Saugeen Ojibwe Nation, as the traditional keepers of these lands. So we thank the Saugeen Ojibwe Nation for providing us these greetings this morning, and they do send their regrets for not being able to be here in person. So with that, we'll get to our first speaker, and we're very lucky today to have Jan Chamberlain with us from the Great Bruce Council on Aging. So welcome, Jan.
Good morning, and I'm one of the lucky ones that have my notes prepared for me too, and I'm not sure if you can maybe see my notes when on here or not, and Emily, you might have to help me if I don't know how to forward this.
It's the wrong presentation.
It's the wrong presentation. Really? Really?
Well, unless you are Sandra Hall.
On the computer, it's right one. Oh, okay. Anyway, I was just going to acknowledge some things too. Thank you, Scott, for doing that with the natives. That's really very important for us. We've been spending a lot of time in our area looking at that. And here today with me from the Council on Aging, I have 4 representatives here. Walden Holiday at the back, and Sandra Pussney at the back, and David Bradley in the front row, and Elder Martin in the front row. So there are 4 other members that are on our council, and I'd like to thank them for coming. It's called moral support, right? So today's thing is called, that's not a thing, today's meeting is called Planning and Health Awareness for Age-Friendly Communities. And so what we're hoping to address here is where in our community, on the spectrum of age community, of age friendliness is where we're at. I'll tell that sentence again. Where is our community on the spectrum of age friendliness? That's what I'm going to be addressing in this presentation. So, for me personally, the status of age friendliness, I have a very positive age friendly experience here, life lived, of course, and many opportunities to be social and to volunteer. And around my housing, I was able to arrange that I could stay in my own home and have a very healthy and active lifestyle living there. So this was a very interesting area of age friendliness when this came up for me way back at the Senior Summit in March of 2014. And that's when the actual forming of the Council on Aging started. It was come from what people told us at the summit, that they wanted to get a voice for seniors that got heard in the area. And we looked at that whole thing, and so we wanted to be a Council on Aging, and we realized there were no other rural type ones, that we mainly could only look at models that were done by cities, and the different cities had a little easier place than we did. But we actually ended up with a very good model where we worked it through that with Grey and Bruce counties having 17 municipalities, we decided that each municipality could be approached to have a seniors advisory committee, and from their seniors advisory committees, they would send one person to the Council on Aging. So we were actually successful in starting in the March of 2015 with 17 representatives from all over Grey and Bruce on our Council for Aging. So I'm going to tell you what we've done since then. When I say that we're the only one that's kind of a rural-based one, the closest one to the same model as we're using is the Grand River Council on Aging, and they cover the city of Brantford and the county of Brant. And they got somewhat the same model. So our model, as I said, is to have 17 committees called senior advisory committees with each of the municipalities sending one person to the Council on Aging, which meets monthly, to do the networking and looking at what we're doing. I have no idea about my notes now, but I'm just going way along here. This is the way I go. Oh, what do people see? Oh, okay, well that's what just makes it easy, doesn't it? Well, you can see that I'm really going along here well in person. Emily, would you like to click in? Because I was screwed up. So I think we're looking at the one right here now, what we do. And this is the map of where we wanted to give you an update on where we've had some really good successes. And we've had presentations, and on this map, it shows we've had, does it have all the names of the big places? No, it doesn't. So we've had one in Owen Sound, Grey Highlands, Southgate, South Bruce Peninsula, West Grey, Brockton, South Bruce, Saugeen Shores, Kincardine, North Bruce Peninsula, and we've done presentations county of, in Grey County, we did it to the Social Services Committee. We've also gone to some, as community groups ask us, we actually do presentations to community groups as well. So we've been to the Salva Sandpipers, the Silver Thread Seniors Group in Durham, the Retired Women's Teachers of Ontario, and the Wyerton branch. I think I'm ready for the next one, right? When we do these presentations, the plan is to have what we call community conversations, and we outline all of the 8 steps that are in the age friendliness model, and we ask for feedback from in each of the groups, and we take notes and get a report organized. So from those reports, we've condensed all of those, and we have some very good information made now, and we were able to do presentations back to the municipalities. So from that, we have some of the ones that have their Senior Advisories Committee already is going really well are, I'm going to mention Hanover separate, Grey Highlands and Southgate. And Elman, you're here from Southgate this morning. And we did several community conversations in those areas to bring that together, and their municipalities have endorsed those Senior Advisory Committees. That is the goal, that each of municipalities would endorse their Senior Advisory Committees, because then there's ways to get information into their strategic plans when they're working on the age-friendly plans. So it's all communication, and it's been working really well. We're really pleased to be here this morning, because this morning was another way for us to realize that we are doing some things in Grey and Bruce. And the next one, I think, is where so these are the ones that have pending, but we're almost there. Is with the Senior Advisory Committees, it's Brockton, Saugeen, North Bruce Peninsula, South Bruce Peninsula, and Kincardine. We're just going to review can you do the next one, please? And so this is what we do with all of the groups, is just talking about the 8 elements. And I don't think we need to spend very much time on this one, other than we know which ones always come to the top all the time, and we have been asked for information, especially on housing, because our seniors have been looking, a lot of people wanting to move to this area are looking at what's available in housing. That seems to be one of the topics, and we can respond to all of these topics. So I think that's where I'm going to end this, because we have a lot to learn today. Thank you very much.
Sorry, we're just going to try to sort out some further technical issues here. Just while I'm doing this, are there any questions for Jan on the Grey Bruce Council on Aging? Hello. So it does work. I think you just have to speak quite closely. Yeah. Sorry, Jan.
As it's endorsed by council, we have them ready to go to their councils to be endorsed, right?
So you have members, committees set up, and it's just, the next step is to be endorsed by council.
That's right.
Presentations have been made.
The goal is to
reports
have a
been
full
done.
session within the next couple of years.
And do you have, do they have the strategic plan or their plan in place already as well to take to council, or is it?
The committee?
Yeah.
No, the committee doesn't do the strategic plan. We're looking at municipalities doing theirs, but looking at
Including
getting inclusion from the committees that are the voice of the seniors in their area. And then the whole group is the seniors for the whole group. And that's our brochure over there, where it says we are the voice of seniors in Grey Bruce. Really big.
Any further questions for Jan? Great. Next up, we have Sheri Walden with us, who's here from Hanover, representing the Hanover age-friendly communities. And Hanover has been, as we heard about from Jan, one of the early leaders in Grey County. So we're thrilled to have Sheri sharing her experiences with us. Yeah, you won't see it on the screen, but you'll see it.
good. I think I'm probably better to just use, so is it the same thing, the slider? Excellent.
Great. Thank you for inviting me. I'm really pleased to be here and to share Hanover's age-friendly story. And it really is a story that I'm going to tell, hopefully. And by all means, if there's pieces that you can use in your own communities or in the work that you do, then by all means, I believe the best ideas are those borrowed ideas. So Hanover, I'm assuming most people know in the room where Hanover is, but just to give you an idea of our population, we are just under that 7,700, and 41% of our residents are 55 years of age or older, with our median age of 47.5 years. We do have a higher than the province's percentage of older adults 55 years of age or older. The provincial average is 30%. And I would assume in Grey and Bruce counties that that's probably most of a stat that our communities are finding. So again, our communities are having older adults, and how do we make sure that our services, a range of services in the 8 domains, are meeting those needs for them to remain in our community actively and enjoy a healthy lifestyle. Our story really began in 2010 with our strategic plan. And as you can see by the slide, we had a recommendation in our healthy community section that we undertake a consultation with our older adults. What we determined to do at that time was to undertake an internal consultation process. And we did so with the support of our regional advisor from the Ministry of Citizenship and Immigration and the Ministry of Tourism, Culture and Sport. And we began with focus groups, as a lot of consultations do in communities, is you identify those key community members and those key community contacts who can come and provide you with that important insight about your community. So that list of contacts is so important. It needs to be comprehensive. You need to have those key individuals. And I would say that one of our learnings out of this was we felt that in that first round of focus groups, we did have a great contact list. We had 52 attendees at our various focus groups. As you can see, it's not on the slide, but our focus groups were, we grouped them faith groups. So that was our churches and our older adult groups within those organizations. Our institutions and agencies, which was assisted living and nursing homes, residence councils that existed within those living spaces, and our regional agencies, so Alzheimer's Society, transportation, the family health team, home and community support services. We then had senior neighborhoods. We have some real pockets of areas in our community that are what we call senior neighborhoods. They're older adult living, they're housing built for older adults, they're attracting older adults. So we identified residents in those areas that we felt were some movers and shakers who would come and provide us with input. We had a baby boomers group, so those individuals who are on the cusp of that retirement age, at a young retirement age, that 53 to 60-ish kind of age range. We just again kind of brainstormed individuals in our community who we knew were about that age and titled them the baby boomers group. And then that all-encompassing group of clubs and services, which was our service clubs, our library, our recreation and social groups. And during those focus groups, we had lively conversation. It was very varied conversation, and there was an immense amount of information. The other key decision we made at this time was, instead of just having the focus groups come to us, we decided that we would also go to some key groups in our community. So we went to them and asked some questions as well. We went to the SMART exercise group, which is the VON exercise group. We went to the Legion during their card day. We went to the library during some of their key activities that involved older adults, and we sought some information from them at that time. Once we had our input, we kind of consolidated that and had a follow-up meeting, was an open space public meeting. And at that time, we provided an overview of our consultation and the information that we had learned at that point in time, and really got the participants at that meeting to think about how, or the action, what are some things that we could do in our community to move some of these ideas forward. At that time, engagement in volunteerism, coordination of activities, healthcare, communication, transportation, activities, meaning recreation and leisure, housing, and accessibility were coming out as a key theme. So again, not unlike the domains that you hear in age-friendly planning, those were some of those key areas. And again, we had multitude of information. So it was taking all that information and attempting to put it into some recommendations from a council perspective. As I noted, our report, so we had a report that was approved by council. It was our older adult conversations report, and we had some recommendations and suggestions around the coordination of activities, the communication, the transportation, the housing, and the accessibility areas. And it was about the same time that the province, there was starting to be some buzz, if I can say, in the province around age-friendly planning. And it was about that same time that the Finding the Right Fit guide came out around age-friendly planning. So our timing seemed to coincide well with that document. One of the, some of the outcomes that came out of that original older adult conversations report were some of the quick wins in our community where we implemented an older adult or a senior rate at our pool. We didn't have an admission rate that was specifically for older adults at that point in time. We implemented a Huff and Puff hockey shinny program for individuals 50 years of age and older. And we now have 2 Huff and Puff shinny times at our arena in the wintertime. And it's a drop-in program. They come and play shinny hockey twice a week. So it's actually, my dad has been involved in a Huff and Puff group kind of in the Huron County area for a number of years. And he will tell me stories of having individuals in their 70s who are still coming out and playing hockey. So that's really a great thing. One of the areas in our coordination of activities, we really were going down a road, or we started to go down a road of to create a central location. There seemed to be a lot of interest, and I shouldn't say interest, there was input from our community about the need for a central location for physical and social activities and information resources. And I think in our communities we often think of a space or a spot that people can go for information. But at the same time, during those information pieces, we heard a lot about probus clubs. And I don't know if you have a probus club in your community or not, but Hanover did not. And so we had a key group of volunteers who then came forward and said, we'd really like to work on establishing a probus club. So we facilitated with those volunteers the research and the information around establishing a probus club. That club launched in September 2014, and they are going strong to this day with 200 plus members and 17 or more activity groups. So while we were going down a path of a spot or a location, the Probus Club meets once a month within the P&H Center and has some great guest speakers and offers that opportunity for social interaction. But aside from that monthly gathering, they have a number of activity groups that exist. They have a potluck club that meets every now and then in people's homes, and they have these great potlucks. They have a walking club. They have a skiing club. They have a bridge club. The bridge players come and play Wednesday morning or Wednesday afternoons in our lobby area. So while we were going down that path of a location, this club was really about having that social and activity-based opportunity for older adults in our community. Without needing a location, they're making that happen within their own realm or resources as well. The other key piece was in our older adult conversations report was a reference to the age-friendly planning and further doing some consultation in that area. So as I said, the timing was really good because of the Finding the Right Fit, but also the age-friendly community planning grant. We made application in 2015 for a grant to undertake a needs assessment process. It was at that time that I received the name of Dr. John Lewis, who was a bit of a leading or involved at the provincial level with age-friendly planning. He was involved in writing the Finding the Right Fit grant. I think I received his phone number from the regional advisor. I didn't know John, but I made what would be called in the sales world a cold call. And I called John and just started asking some questions. I explained that we were looking at making an application. Could he provide me with some insight? I shared some of the information and work that Hanover had been doing. And to this day, Dr. Lewis, through the University of Waterloo and his involvement with the Senior Secretariat, has remained involved and been an excellent resource for the work that we have done. We were successful in receiving a grant, one of the very few rural communities who did receive some grant money, so we were pleased to have that opportunity. We were approved for up to $25,000 to undertake an age-friendly workshop, establish a steering committee, have focus groups, and undertake that needs assessment process. Our launch occurred in November of 2015. It was a really strong attendance. We had well over 90 individuals there. We launched at that time My Community Vision, which was something we had partnered with Dr. Lewis through a company that he has, and it was an input process using an application electronically that mapped Hanover, but also included an input piece around the age-friendly domains. So the beauty of it was that you could attach flags or pins, as we called them, of positive information or perhaps some suggested information. Maybe there was an intersection in our community that the signaled lights needed to be longer for walking across. We could make that note directly on the map. So it was new, it was developed, and it was an opportunity for us to test that and use that. Next, our needs assessment report. Again, we went and we had focus groups again using the My Community Vision. We had surveys. One of the notions we had set at a time of application for our grant is that we would establish a committee. We chose at that time, or decided that, okay, let's hold that thought and implement a committee when we had some action. So some action out of the needs assessment. I'm going to mention in a little bit how a lesson learned out of that was, and in a little bit of time. But our focus groups were, again, an opportunity to bring some key community members together and provide us with some very specific information around that age-friendly planning piece. A little more difficult this time to get those individuals out to those focus groups. It may have been a timing thing. So that's a really key thing with your focus groups, that key comprehensive list, but just that timing piece is important too. And as I mentioned, one of the lessons learned was around not establishing those key committee or a steering committee to oversee that needs assessment process. Is we feel that had we have done that, we would have had some community champions out there who would have been championing the attendance at those focus groups. So that was, again, key learning. I'm assuming needs assessment report is showing on your screen, correct? Am I right? No? No. So I'm a bit behind, sorry. Or this isn't working.
Maybe try just using the keyboard.
I will. I should have, well, that doesn't seem to be working either, Scott. Let's just get arrows correct. Sorry, I've been clicking along. I should have done a check-in a little bit sooner.
We might have to wait till the next.
That's fine.
Sorry.
I'll just keep speaking. That's not a problem. So out of our needs assessment report approved by Council in December 2016, there was 4 recommendation areas, and that's on the screen. So the 4 recommendation areas were public space accessibility, and it dealt with things around benches and pedestrian signals at crosswalks and having an accessibility strategy. Social support, which was around our recreational and social activities, and our isolated older adults. Our specialized services, so things like home support and transportation and advocating our government agencies, and information and communication, so communication strategy and guidelines, as well as creating an age-friendly information hub. The other recommendation was that we establish an age-friendly advisory committee, which we have done in Hanover. We have established a committee as of June 2017. We have a very specific terms of reference, and the goal of that committee is to serve in an advisory committee to council to make Hanover an age-friendly community, enabling all residents to participate as full and meaningful community members while building age awareness or age-friendly awareness plans. We have a great cross-section of members on our committee who wear varied hats and bring varied information around the age-friendly domains, which Jan had mentioned in her presentation, so I'm not going to repeat those. We also have agency representatives, so we have Sandra from the Alzheimer's Society, we have Grey County Housing represented, and we have the health unit represented as well. So it's not just a community committee. There are regional agencies represented, which has been really important to the work that we are doing. So we've been building our committee awareness with guest speakers as well as our action plan development. And we have been successful with 2 of the senior community grant application periods. So in 2017, we had a grant that allowed us to launch an age-friendly speaker series. So it was having speaker opportunities for our community members to learn about various services and information in and around our community, as well as to have conversations with our groups about communication methods and how could we cooperatively work together as a group or as agencies to ensure our messages were getting across to our older adult residents. Our 2018 application, which we have received approval for, is to enhance our Senior Star newsletter. We have a newsletter that goes out to our residents, or I shouldn't say it goes out, it will be going out to our residents twice a year, but it was available twice a year for pickup in various locations. So we are enhancing that communication piece with this current grant and actually mail dropping it to all of our residents. And the other exciting piece that we're undertaking is a walkability assessment of our community to provide us with some insight about how walkable is our community, specifically thinking of our older adults and how they get around. So that's kind of where we're at. And again, we're plugging along slowly but surely. So it's about time. It does take time, and I think it's about building awareness is the other key piece as well. So that's the end. If there's any specific questions that I might answer, and also certainly here at the panel time as well. So.
Yes, Sheri. What was the key, you think, in receiving the grants? Because we applied for grants.
Right.
So what do you think
So
was the difference?
I believe, and this is my own opinion because I didn't have that from the consulting, but I believe the prior work we had done with the older adult conversations report, so some of our strategic plan work that we had done prior to applying, I believe that helped us in our grant application in the sense that we had shown A, commitment to that planning, B, we had already had some work that we had completed which identified the need to do more work. And so that was certainly the key around the application. Now the Seniors Community Grant application success, we haven't asked for a lot of money. I think our first one was around $2,000 and our second one is around $7,000. So again, I think the work that we have been doing and tying it to our needs assessment and some of the pieces within that have been important to show that there's that need for that work.
So there was credibility there.
Yes, that would be a good word to use. That would be a good word to use. Yes.
Hi, Sheri. Thanks for your talk. I was wondering what you think helps Hanover become an early adopter of the age-friendly strategy. Is it something about the council or the community itself, or the work? Obviously, maybe you answered part of that in the last question.
Right. So I think our strategic plan and that so 2010 was our very first strategic plan process as a community. And it very clearly identified needing to do some work with our older adults. So I would say, yes, it corporately was a direction that council wanted to go. I think our population speaks for itself. There's a need to do that in our community because of our population. And just having that drive within, the staff complement to follow through. Yes?
So, City of the Backer, we're all land use planners, so my question is framed around that built form.
Yes.
And I appreciate in some cases you're in the infancy of some of this. Are you seeing anything out of the Probus clubs or commentary that you've seen thus far related to the aging population might see a different built form? I was intrigued to find out that initially they weren't talking about bricks and mortar, they didn't need new recreation centers.
Right.
But are you finding requests for trails or certain type of trails, what's on the trails, or certain things where there would be land use planning?
Right.
associated with that?
So we are infancy, but we're starting to hear things like that. I would say things around walkability are important and thinking about that timing of crosswalks and the ability to have benches in key areas. From a land planning perspective, right, and I think of our own community, we have, through our downtown revitalization, implemented some more benches in our downtown core. That was from a downtown revitalization standpoint, but they came to us to ask where should those benches go, right? And I think we're going to hear on our walkability assessment, I expect that we will hear the need for more benches, but from a land planning perspective is, okay, we need space to put those benches that then allow for snow removal and all those other things, right? So it's accommodating those, what seem like simple things, but allowing for that to happen from a planning perspective. From a trails, I think we will hear some more about our trails around accessibility, having charging stations, and the ability to charge scooters potentially, right? That if they are using their scooter on the trail, but can only go so far, how do we allow them to have a charging station somewhere? So we may hear that. I'm thinking we may. So those are some, but yeah, we definitely are in that early stage of that type of thing. And I think housing is the other one. Just that planning of where the housing is that allows them to be in their own homes, but able to access some of those other spaces. So.
Just to follow on that, similar comments, other one that come up for us, I think, around universal design, changes to the building code, but also complete streets.
Yeah. I can use a really specific example in Hanover. So we have what I call one of our senior neighborhoods, and it's duplexes, townhouse type, and it's very old. They're for older adults. That's what they've been built for. And so interestingly enough, the sidewalk went, and so we cleared the sidewalk as a town, which is fine. But where the housing was and where they could access the sidewalk, where the curb, where it went to the curb, was almost half a block. So they had to walk on the road to get to the end of the sidewalk to be able to access the sidewalk, where it was almost like, could we have provided a curb partway down the sidewalk that would allow them to come across the road from their residences and access the sidewalk. So it's simple. I shouldn't say simple things. Sometimes those aren't simple things. I know that, but it's kind of those types of things that unless it was the older adults at one of our focus groups. He said, well, we can't even get on the sidewalk without walking a half a block. So it was like, that's a good point. So
Remember the days when they had a baby here?
Right. So I'm probably over time for questions, and I'm, again, here for the panel part, so thank you.
So I apologize for the technology issues. We're going to try one more thing, just the old-fashioned plugging and unplugging. That's the extent of my IT skills.
While they're doing that, I was going to chime in on what you said about the building code, and we are 37% of the homes in Grandview were built in 1960 or before. So you can change the building code all you like. The homes that were built in 1960 and earlier are probably not going to be close to those.
And ironically, you can't get a wheelchair around that counter.
Yes, and also a lot of homes were constructed without significant insulation because it was very cold in every room. It was really safe. But there was drop protections put in so that when you come in the front door, a wall is there to protect from the drop coming in. And so not only can you not get a wheelchair, you can get stretcher fires in there. Yes, we are not doing an open concept. Yes.
Well, we could all talk to your engineering departments, because we in the planning industry love to see roll curves, and straight curves, and engineers, if there's any engineers in the room, I apologize, but they typically like a different type of curve pattern. So it's always a battle in the back rooms, finding the engineers what curve looks like.
Excellent. So I'm going to suggest that's the last of our technology issues, and be smooth sailing from here, so not going to jinx anything. So with that being said, we're really excited to have Sandra Hong with us from the Grey Bruce Alzheimer's Society. Sandra was nice enough to come and present to our planning staff And as soon as she left the room, we thought, well, where can we use her again? How can we get her here again? Because she had a really great message, so we're excited for her to be able to share that with you today. So welcome, Sarah.
And I'm excited to be here. I'm always excited to share how it is that communities can become more dementia friendly. So thank you for having me. So I'd like to begin with a quote. Having dementia is very tough, but having a city who excludes dementia, that is really tough. So what exactly is dementia? Just briefly, dementia is a set of symptoms that include loss of memory, reasoning, our ability to function with day-to-day activity. So we always are trying to determine what is the cause of this dementia. And with the Alzheimer's Society, it's looking at irreversible causes. So we're supporting individuals with irreversible causes such as Alzheimer's disease, vascular dementia, Lewy body dementia, frontal temporal dementia. So there's a lot of dementia, a lot of irreversible dementias out there that the Alzheimer's Society supports individuals with. So I didn't include this in my slide, but just so that you know that individuals with a dementia, they are all unique in what their symptoms look like. So they may have difficulties with language. So talking to the bus driver, for example, as to which route they need to go on to. Their sentences may appear as though it's a word salad. They may have difficulty with recognition. So exactly, where am I? I was heading to the grocery store, and now I'm not really sure which direction to go. Even the recognition of who you are. So maybe it's at the bank teller that they've gone to for the last 15 years, but now they're having difficulty identifying who that bank teller is. Purposeful movement, so the ability to actually step onto the bus, getting their leg up and moving, getting that message down to their leg to pick up. The self-awareness, so loss of recognition of their ability to know that there is anything wrong. So maybe they step into a grocery store and shopping around, and there's a bottle of Tylenol on the shelf, and they slip that into their pocket, not realizing that they haven't paid for it. And understanding the environment again, so their perception issues. Maybe they're looking outside and they see children playing, but the children aren't actually, there's no children outside that window, there's actually just a bush out there. So all of these symptoms are experiences that an individual with dementia may experience. As I mentioned earlier, every individual is unique in those symptoms. So what we do at the Alzheimer's Society, we like to be there at the time of diagnosis. So we participate in 13 memory clinics across Grey Bruce. We promote early involvement with education and support programs. And we help individuals and families make the challenging journey in an atmosphere of love and understanding. So just giving you some numbers, our new prevalence numbers tell us that each year 25,000 Canadians are diagnosed with dementia. Dementia is the most significant cause of disability among Canadians ages 65 and over. 1 in 3 Canadians over 80 years of age is living with dementia, and 1 in 11 Canadians ages 65 and over. 1 new case is diagnosed every 5 minutes. The elderly portion of the population, those aged 65 and over, will continue to increase greatly by over 41% by 2020 and 125% by 2036. So the prevalence numbers of dementia is also increasing rapidly. By 2020, the increase will be nearly 37%, and by 2036, that increase will be nearly 156%. So while the risk of dementia increases with age, 2 to 10% of the people with dementia are actually under the age of 65. In 2013, more than 8,900 community dwelling Ontarians between the ages of 40 and 65 were living with a diagnosis of dementia, 9% of the total community dwelling population. So it's not just their disease, it's ours too. This slide, just sorry about the busyness of it all, but based on a Hopkins report that was done in 2010, the population, they predicted the population of individuals living with dementia in Grey County would be about 2,374 individuals. Now, what we are aware of is only about 1/3 of individuals actually seek a diagnosis. So the true number is probably closer to about 7,000 individuals in Grey County with a diagnosis of Alzheimer's disease or other form of dementia. So a dementia-friendly community is a place where people with dementia are understood, respected, and supported. It's a place where they can feel confident that they can contribute to community life. In a dementia-friendly community, people will be aware of and understand dementia, and people with dementia will feel included. They'll feel involved and have choice and control over their day-to-day lives. Individuals, neighborhoods, organizations, agencies, and geographical areas work together to support people with dementia and their care partners to live safe, active lives in the community by becoming educated, generating awareness, and breaking through the stigma. So we really want that community, a dementia-friendly community, to understand that dementia, to understand the diagnosis of dementia and the challenges that people with dementia, living with dementia face. We want them to include people living with dementia in all aspects of community life, and encourage these individuals to be independent. We also want to assist people with dementia in the most appropriate and dignified way, and value what they have to say in their businesses and in the establishments within the community. So the ultimate goal of these points is to really bring home or remove the stigma of individuals who may be concerned about their memory, and fostering meaningful engagement for these individuals of all ages and all groups. So in tiers, when we look at tiers to a dementia-friendly community, we can break that down. First, there is the invisible network of businesses, healthcare workers, emergency services, personnel, and other civic employees who are trained and prepared to respond to the needs of persons with dementia within the community. So this actual network requires a top-down approach, right? It's good to involve the individuals with dementia, but also from the top down, getting those people on board to become more educated and knowledgeable about the disease process. Secondly, is the more visible, so the grassroots individuals. So that network is bottom up, and it's comprised by the persons with dementia engaging in the socially in their community, in the planning and building of a dementia-friendly community. So there is need to recognize both tiers in the development of the dementia-friendly community, so we can't exclude either one in order to be successful. So several domains in in regards to building a dementia-friendly community, and those domains are public awareness and information access, planning processes, the physical environment, access and consideration for dementia among local businesses and public services, community-based innovation services through local action, and access to transportation. And I just wanted to, I'm going to expand on each of those and let you know where we are in Grey County in each of those domains. So in terms of public awareness and information, first of all, there's always more work can always be done in the sphere of public awareness and information. And we know that, well, there has been quite an increase, I guess, in terms of dementia-related films or television and movie stories, media releases about dementia. It's what is actually happening locally that we can get this information out to individuals. So certainly our involvement in the memory clinics helps at the time of diagnosis to support individuals early in their diagnosis. Programs and services including education series for care partners and people living with dementia. So that's our learning series that we offer for not only people living with dementia, but also their care partners. Supportive housing. So I had working collaboratively with supportive housing through Grey County and being working with their Koala program in partnership, so that I'm there as someone that they can talk to at the time of their appointment with the Koala program if they have any concerns about their memory or concerns about a friend or a family member, either in the building or outside. So giving them that opportunity to have that information available to them. Law enforcement, so working with the OPPI and municipal police on educating about how the officers can approach an individual who may have Alzheimer's disease or other dementia. This program called Finding Your Way really educates the law enforcement officers on what to do with when they come across somebody who is lost or missing, how they can approach them in a calm way and so forth. So working collaboratively with the law enforcement. Awareness presentations are ongoing in our community, so doing presentations to service clubs and faith-based communities, social groups, and also being present at health fairs to educate people on supports available through the Alzheimer's Society. So the planning process. So having people with dementia who would be willing to sit on a committee to assist with planning in order to successfully develop a planning process must always come first. Then the carers, then the professionals and the experts. However, one of the biggest challenges in creating dementia-friendly communities is getting the public talking about dementia. So we need to create that atmosphere of understanding and support so that people living with dementia and their care partners will feel comfortable talking about their condition. The physical environment, how we can change the physical environment so that it's more supportive for individuals with dementia. And this is just a slide to give you an idea of what a public washroom might look like to support a person with dementia. So you see the contrasting colors of the toilet seats and the handrails. And the outside spaces, so handles to the doorways in contrasting colors, those park benches to sit on, contrasting handrails, clear identified step markers for the individuals. So community-based innovation services through local action. What are we doing in Grey County in terms of that? And that's really about our art educational, where we have volunteers from the high school sitting with people living with dementia and writing their stories. And Minds in Motion is an interactive exercise and intellectual component of a program that we offer to people living with dementias and their care partners. The caregiver support, so what we are doing in Grey County, we cannot forget or recognize what the caregivers are doing out there to support their loved ones with dementia, because as the progression of the disease increases, the caregiver support increases as well. We have care partner support groups that are available. We have education series for care partners. We certainly refer to home and community support services, and Home and Community Care Southwest Lynn is available for that caregiver support as well. Behavioral Supports Ontario, which I won't expand on because Charlotte's here and we'll talk about that. And there's also a care partner support group for VON. So what's the one thing a person with dementia needs most of all? They need a friend. And recognizing that our engagement with an individual with dementia can certainly impact that individual's day. So let's make that day a good day. So staying safe in the community for individuals living with dementia relies quite heavily on the community itself. Thank you. Yes.
Going back to this supportive housing, other than the colors, is there anything else, like as far as from an age-friendly perspective or the age-friendly lens, or the planning lens, how do you, the housing, how do you do that dementia friendly?
How do you make it, yeah. So it's quite a process, right? And I guess what we could do is just giving design ideas and then you having to pass that through the planning and the design of the building makeup, whether they could afford to make those adjustments and fulfill them. Are you specifically thinking individual housing or the whole supportive housing building?
Individual housing as well as, like even walking in here today, this is not a dementia friendly.
Yes.
building.
Yeah, they didn't involve us in that.
And I'm not trying to pick out anything, but I mean, that's what I'm asking is what could be done.
So there is a website, and actually the images that I used in the physical design was through an Australian website that gave ideas as to what kind of things you could do to your design, the contrasting toilet seats, the contrasting grab bars, being really aware of the color of your carpeting and the patterns on the carpet, how individuals with Alzheimer's disease and their perception is, or the vision is impacted by the disease process. So, patterns, dark lines may appear as though they're cracks or holes in the ground. So they're not going to walk past that, or they're going to take a big step over it. First step is really understanding how the disease impacts the individual, and the next step is how can we change this environment so that it works better for this individual.
So thank you for that, Sandra. Next up, we have our first refreshment break, so we'll try to come back for 10:50. As I said, the washrooms are just through here, refreshments are here. If there's anything else you need, just ask Helen, Hiba, Stephanie, or I, and I'm sure we can find it. So thank you.
along with myself. So, Emily.
Thank you. I'm not going to speak into the mic because I'm really loud anyway, and I'm not sure that it's amplifying that much. So thank you for having me, and the typo that brought me here. So I do work through the public health unit. I'm funded through the Southwest LIN. I sit on the Council on Aging. I wear so many hats that I can't even figure out which hat I'm wearing at which moment. But today I'm going to tell you a little bit about what's happening in our region in terms of aging, and a lot of that is going to come from the census. So public health, we love the census. No one else loves it like we do, because it tells us a lot more about our community and allows us to advocate for certain things that we need to hear. So here's a picture of what we look like, and those numbers are the population density. So that's the number of people per square kilometer. So as you can see, we're really close to Toronto, really dense around here, kind of big time. So in Toronto, per square kilometer, there's 4,300 plus people, and we have about 18 in Grand Bruce. And so what that means for every program I've ever worked for, which as some of you may know, I'm also a professional at being laid off on mat leave, so I've worn many hats in my career. Every single program I've worked with, our geography creates challenges and costs that are never anticipated in the city. And when things are planned in the city, they're not planned keeping that in mind, that people are going to have to travel really far to access services, that service providers are going to have to travel really far to access people. And although we complain of that all the time, when we're working in Owenstown, we can still do it ourselves, or in Hanover probably as well, where we forget about those really rural people. We also have people that commute really far. Our commute time is about the same, but we're going much longer distances than people are in Toronto. So this is how many people live here. This is from the census from last year. I do have to note that anything that we provide that's based on the census, there's always a caveat with census data. But one of the things that's important to recognize is that we have really low response rates for the census on the two Indigenous reserves. And so that data is really not captured, and we don't report on it because their participation in the census is in like the 30% range. So we have low growth of 2%, but it's better than the last census where we had 0.1% growth. And on average, people are older in our area. The average is a little bit less exciting than the number of people who are 65 and over. So in Grand Bruce together, we are almost 24% that are 65 and over. And this census was the first time in history where there were more people in the 65 and older range than there were children. So that's a bit of a problem. I had 3 kids, so I did mine first. We have certain areas where we have older pockets as well. So Grey County is home to over 22,000 older adults, and Bruce County 16,000. So, and once again, that's almost 24% of the population. The provincial average is 16.7. The population is 65 and over, and Canada is almost the same, it's 16.9. When the census came out and they were talking about it in terms of all of Canada and aging, they said, oh my goodness, by 2060, we're going to have 23 to 28% of our population is going to be 65 and over. We need to start planning for this, and we're already there. So that's interesting. Some of our certain areas, we have higher numbers of older adults. So Owenstown, Leaford, Saugeen Shores, and Hanover have more older adults So you can see Ontario's 12%, and when you average ours, it looks like we're very similar. But I think it's really important to see that there are certain areas that have really high rates of low income. And when you put that together with the other things that are going on for those people and what their community looks like, it paints a slightly different picture. So for example, Southgate is our highest. And for those of you who aren't familiar with Southgate, Southgate does not have a lot of services and shops and things that people can access. They have transportation issues. And they also have higher rates of low income in that area. So you put all those things together, it paints a more difficult picture for somebody to age well in Southgate.
What are you using for a range of low income?
The low income range is very complicated. Can I tell you that after? It's based on the low income measure. And I have a really hard time explaining that to you right here, but I can get that for you.
Okay.
The other thing that we've been able to do from our epidemiology department is look at putting together profiles by municipality, and so that's something that's coming up soon. And I think that started with Alvin. We pulled some of the data just for Southgate, because when you look at aging alone or housing alone, it doesn't do the same thing as looking at the whole municipality, and so there will be more of that. I can explain that to you after the meeting. So I work in falls prevention. Everyone likes to think that falls have a single reason why someone fell. And if I were to ask you, have you had a fall, tell me why you fell, people would usually give one reason. And everybody would love there to be one reason. Because if it was just handrails, we could just put handrails everywhere, and then nobody would fall. But people fall on the stairs because they're carrying laundry, and the baby pukes in the floor, and the phone's ringing, and they're wearing stockings, and they have wooden stairs, not just because of one thing. It's always lots of things that come together. And so we need to look at a multitude of factors when we're trying to prevent a fall from the individual and the environment that they live in. In our region, 24 people visit emergency every day for a fall. And we have a 72% higher age standardized rate of emergency preparedness visit for falls. And everyone always says that's because we use our emergency departments as walk-in clinics, but it's not, because we also have higher rates of hospitalization for a fall. We also know that between 2 and 3 people die every month in Veracruz for fall-related injury. And so those are just the falls that we know about. This chart shows you the dots are Ontario, and the graph is us. And so this is our range of emergency department visits for falls. We have really high rates across the board, but we also have really high rates in youth in our area, which is interesting. People think of falls as a problem of aging and of older adults, but we have really, we're 125% higher in our 5 to 24-year-olds.
Thanks, Emily. So we have Dr. Brendan Mulroy to speak next. And just as an FYI for everyone, we'll have these presentations posted on our website so everyone can download them and read them and access them following, just for your review.
So hi everyone, and thanks for having me. If you didn't read the bio, I have been in Old Sound for just a little bit over 30 years. I worked the first 20 years as a family doc. The last 10 years, I've been able to do really interesting stuff, at least interesting to me, and I was working more with the elderly. I always had a big interest in that. I came to Old Sound and I took over an older practice. So that's where most of my continuing medical education had to be. Those are the patients that I had. And yeah, for me, it's exciting. I think I'm sort of a geriatrician at heart. I just love taking a history from people and hearing about their lives. My brother, who's an oncologist, he just laughs at me, but I still get excited about taking a history from people. That sort of gives me a real charge. So you're probably wondering why I called it the promiscuous disease. I gave a variation of this talk at the hospital, and I was worried that nobody's going to come. He's going to talk again. It's going to be about dementia. So I thought I'd jazz it up a little bit. I used this title, and yeah, people came. They, of course, thought it was going to be about sexual promiscuity, and we did get a little bit of that in the dementia world, but I was really using promiscuous more in the sense of being a little bit indiscriminate. And one of the reasons I had hit on that kind of topic was because we had started doing these outpatient clinics. I do them with Charlotte, who will be speaking to you next. And in these outpatient clinics, within the first 6 months, we saw 5 retired university professors in this area. And they were all showing signs of dementia. I thought, wow, what's going on here? I thought education was supposed to protect your brain. So I'll come back to that. We'll talk a little bit more about those 5 professors. I'm going to hit the red button. That's not the one. Was it right? To the right, yeah. Gotcha. Okay. So, yeah, I'm going to give you a little bit of an update on what's happening in the world of dementia. We'll look at risk factors. In medicine, we're supposed to always do disclosures. So I want you to know I'm a family doctor. I see people and they're always telling me or saying that they saw the psychiatrist, that they saw the geriatrician. I am neither. I'm just a family doctor with an interest in, and that's the beauty of medicine. If you have an interest, particularly family medicine, you can pursue that, whether it's sports medicine, kids and falls perhaps, epidemiology. For me, it's been the elderly and dementia. Before I get started on the diagnosis, I'll just add that I don't wear as many hats as Emily, but she and I actually gave a presentation together, I think it was about 10 years ago. I think you did the slides, so that's why hers are jazzier than mine. I'm still struggling to catch up in that area. I think we're both sort of closet epidemiologists. Maybe you're a little bit more out of the closet than me, but I'm going to hit upon some of the same statistics that you gave, maybe from a different perspective. Anyway, coming back to dementia. You'll see that the diagnostic criteria here is saying that we need to have a person who is showing impairment in at least 2 of those areas. Memory, reasoning, visuospatial, language, or a change in their personality behavior. And that impairment is affecting their ability to function in their home life or at work. And it's got to be a decline from previous. Because we do get referrals, and it's a person who has had developmental delay all their life. So it's a really difficult one to make a call. Are they now getting dementia late in life? I mean, that can happen, but if their functional level has always been pretty low, it's hard to gauge how much lower they are now at. And again, to make the diagnosis, we have to rule out that there's no delirium here. Depression often it masks itself as well with dementia. And we have to rule out an underlying psychiatric disorder. So the big change in this is that in the past, the diagnosis was always there has to be memory impairment. You know, and again, we used to think, well, you have to have that to talk about dementia. We began to realize as we learned more about dementia that no, some people present, and their memory is pretty good, but their ability to function is declining. You know, their behavior is changing, and we began realizing, yeah, there are other types of dementia outside of Alzheimer's, and they don't always come in with that first sign of short-term memory loss. So here we look at a little bit of the list of the types of dementia. So you'll see Alzheimer's, again, we used to think it was all of dementia, 100%. Alzheimer's Society, I think, still regrets a little bit, you know, taking that name. So you change your tagline, I think, it's Alzheimer's and related dementias. But now they're listing Alzheimer's in the 60 to 70% range. I think that's still probably high. I think as we learn more and more, we're going to realize vascular dementia is even bigger. And that'll chip away at the numbers for Alzheimer's type. We're discovering more and more of the other types of dementia. So again, Parkinson's inevitably leads into a dementia. Again, it depends on the timing of when their dementia starts. If they've been a long time with Parkinson's disease and they get dementia, we call that Parkinson's dementia. If they've just developed their Parkinson's and very quickly are showing features of dementia, we'll generally refer to that as a Lewy body type dementia. The difference there is it's a little bit academic, but yeah, the academics will always distinguish between those two. Frontotemporal dementia. We don't see very much of it, but again, perhaps our diagnostic criteria looking at that is not where it should be. We may see that area expand. But these are, again, it's becoming more defined. There's the frontotemporal dementia behavioral variants. So those are the people who just start behaving bizarrely. You know, they'll talk very loudly in a restaurant about the people at the other table who are annoying them, and they never used to make those kind of comments or behavior in public. So, you know, what's happening to mom or dad that they're doing this? So that's the behavioral variant. But now we're also seeing a whole category of frontotemporal and it's language where these people are starting to struggle. They talk about reversible dementia, and that's a bit of a misnomer. You know, if you're going to give somebody the label of dementia, it's a progressive disease. Once they've got it, yeah, they're going to get worse. So where does this reversible idea come from? Well, we see some people, and they are functioning poorly, but they're on a bucket load of medication. And I was trained as a family doctor. Doctors like to give medication. We're not very good at stopping medication. And you know, when a person hits age 70, 75, the medications they needed at age 50 may not apply anymore. So it's time to get rid of a lot of those medications. We talk about drugs with cholinergic side effect, and that if they have that, then they impact on the brain and people's ability to process information and retain information. So some of those are fairly simple medications that are in your world over the counter. So the first generation don't want to use that drug in the elderly anymore. Maybe when they were 50, but not at age 70, 75, 80, 85. Another commonly used one would be warfarin. If somebody's on it for a blood clot or atrial fibrillation, uncontrolled heart rate, the risk of blood clot and stroke is there, but warfarin affects brain function. So there are newer agents out there, and these people should be moved over to them. And again, I'm always sort of harping at the family docs that, guys, we have to look at the drug list here, get rid of a lot of those drugs, or change some of them. Alcohol. It always sneaks up on us. Shouldn't sneak up, I suppose. Lean on Emily here, but I think falls in Grand Bruce County. We have pretty high rates of alcoholism here. So for our area, we always dig into the history to pick up on that. And again, a lot of people are closet drinkers. You wouldn't imagine so-and-so was such a drinker, and then you realize how much they're imbibing, and it affects brain function. So if we can get them off the alcohol, those are the ones where you'll see really dramatic improvement. And that improvement, it doesn't come in just in the first 2 weeks of withdrawal, first month of withdrawal. Some of these people are still improving 2 and 3 years after they quit drinking. So it shows how profound the effect on the brain that alcohol has. Mixed dementia, I use that term quite commonly because, again, I don't see very many people anymore under the age of 75. So, yes, the statement used to be, if you live long enough, you're going to get Alzheimer's dementia. Some people get it at age 60, others 70, 80, 90, 100. That's how we used to approach it. But now, they'll sneak it in that, if you live long enough, you're going to get vascular dementia. And it happens, the vessels supplying various areas of the brain just clog up, unfortunately, and people's brain function starts to decline. So we get that vascular component. But in the world I work in, we see features of both, and we see people in an age bracket that fit for both of those disease types of dementia. By the way, I'm happy to take questions at any time. I don't mind being interrupted. At the hospital, I would have been interrupted 20 times by now, questioning me about something I said. So yes.
I was just wondering with early onset dementia, because you don't see too many people over 75, are family doctors picking that up in the view because we've heard the standard that there's still a lot of people undiagnosed and think that some of them can early onset as well.
Yeah, my apologies. I missed Sam's talk. Yeah, I don't see the early onset because hopefully the family doctor is picking that up. Those are the ones that we want to get them to London in a hurry. Because again, London is doing some of the trials that may have a huge impact on their life. If they're only 50, gosh, yeah, you want to do as much as you can for a person for their remaining lifetime, which still might be. We used to think dementia was 7 years from the time you diagnosed it to die. No, that's gone out the window. So this person who's early onset, we had a young woman, she was 46. Unfortunately, she didn't live very much longer. But some of them diagnosed in their 40s, yeah, they might still have a 20, 25, 30-year lifetime dealing with their dementia. So if I get anybody, but I don't see very many of those, yeah, we want them down in London and assess them.
One other question about those persons with intellectual disabilities, perhaps Down syndrome, but living in the community. I've noticed as I moved to the county that I see the community living more visible
family doctors, so you're the quarterback, and I think family doctors need to be constantly reminded that they're the quarterback. You know, they're on top of this patient, the whole person. The cardiologist gave them this cardiac medication when they were age 50, and maybe they had had a viral myositis that affected heart function. But now they're 85, and should they really still be on that drug? Family doctors are afraid to stop the drug because the cardiologist will put them on. So there's that kind of hierarchy in medicine. Family doctors don't assert themselves enough, I think, to say, no, this drug is inappropriate for this person at this point in their life.
Does it help if the pharmacist has said, I'm pharmacist sort of backs you and say this drug is inappropriate in my opinion? Would that be enough to convince?
I think so. I get to work with a lot of great pharmacists at the hospital. So I listen to them, you know, if they say something to me. I think the younger generation of family docs coming out are schooled that way, that, yeah, they'll listen to the pharmacist. The older generation of family docs sort of thought that they're above the pharmacist, and if he's saying that, no, I'm going to disagree.
Oh, yeah.
There's a little bit of that.
Yeah.
Incidence and prevalence of dementia. Again, the epidemiologists in the room are excited to see that the numbers, percentage numbers, are both in decline. So we think, why is this? Because people are getting the message and they're being more active. Family doctors are doing a great job in terms of controlling the diabetics and controlling the people with high blood pressure. So we're seeing a drop in the incidence of stroke, and stroke then contributes a lot to the vascular component of dementia. So in terms of percentages, yeah, the numbers are falling. The hard numbers, though, again, we have that aging population, so the hard numbers, we're still seeing more and more people with the disease, but the percentage of people with the disease is low. I came across this, and I was actually quite stunned when I first saw it. These are American statistics, but I think in this area, across the board, we're comparable to the States, and we're just sort of 1/10 of everything they do. But again, you look at it, 30% of the time that a family has to commit and the money that they have to put into the care of someone. I thought it would be huge for the stroke people. I thought it would be huge for the diabetics, because we hear so much about all the complications that diabetics run into. I thought it would be huge for the COPD people. We see them at the hospital all the time. They're struggling. They've got their oxygen tank with them. They're barely able to get around. But 30% is devoted to looking after people with dementia. So pretty stunning, I think, in the amount of time and money that is being invested into care of the demented people. Again, Emily hit on this one. We are at that dramatic point in the history of the world where the number of people older than age 65 is greater than the number of children under age 5. The world has never seen this before. It was always a young population. So public health has done a great job keeping us alive, but we've never encountered this situation before. There's this ratio, Emily, you might know old age dependency. The number of young people you have who are out there actively working and able to support the elderly, pumping up the economy, keeping that going. We're going to get into trouble. We already are seeing that on the East Coast. New Brunswick, Nova Scotia, Quebec, and now Ontario. We're getting so many more elderly people. Alberta is in a different world than I think BC, because all those young people, not historically, but in my generation, were migrating out there. So they're still doing pretty well. But we, again, are becoming an old population. Again, the world population in 1950 was 2.5 billion. So where are we now? It's 7.6. terrifying for them. Then someone's going to attack them with a needle. We save them a tremendous amount of trauma on a weekly basis. So again, that's how I would advocate, and we're trying to get that message out because we review cases every week, and we're trying to send that information to family doctors and saying, yeah, time to make a change in the drug. Thank you.
And also advocate for trauma care on a prevention basis.
Yeah. So the higher ups, way above me, are certainly taking that to the Ministry of Health and the Ontario Drug Benefit Plan, saying it's time to make some changes and allowances here in what we will automatically allow for the elderly. So hopefully in a few years we'll see that change. I've got to finish up here. So how do we minimize dementia? You've heard this, but more and more it comes back to keeping the person's brain stimulated. Socialization, we see it time after time. The person's living on their own. We don't want to take them out of that familiar environment. They love their home, but they're not doing well. They're struggling. Family is doing the best they can. They move into a retirement home or a nursing home, and suddenly they're reborn. They come alive again because they're talking to people. They're talking to the staff who are coming out to check on them. They're taking part in the recreational activities on a regular basis. And it's lovely to see the change we get. Of course, North American diet has been hammered to death. We've got to get better on that. Physical activity, study after study, keeps ranking above the drugs. Drug companies are going crazy because they try and say to you that, oh yeah, this drug is a cure for dementia. No, it's not a cure. Maybe it keeps them functioning at the level they're at for a little bit longer. Very rarely we see a person who shows improvement when they start one of the memory drugs, so-called. But the drugs just aren't doing it. To hit on that theme, Pfizer, one of the major drug companies, in January announced that it was pulling out all of its research monies from a drug investigation for dementia and for Parkinson's disease. They've just abandoned the field. Pretty scary. Why are they doing that? Well, because time after time we're bringing drugs out, or they're bringing drugs out, and they can't get them past stage 3 trials. For whatever reason, the drug is shown to have no effect, or it's too dangerous to be given. So they can't see that there's going to be a win at the end for them, so they're not investing. And the question then becomes, have we been barking up the wrong tree in what we think is the cause of dementia? Now, you've heard about the plaques and tangles in the brain. The amyloid deposits, that's the plaque. The tangle is tau. The research seemed to indicate that, this is what causes dementia. And then they began to realize, people can have a lot of amyloid. In the States, they now use the assay. People routinely go for their brain scan to see how much amyloid they've got. Thankfully, in Canada so far, we're not going in that direction, but Americans love doing that kind of stuff. So they're seeing these people with lots of amyloid, but they don't have the disease. Why is that? So then the theory became, they've got to have the tau there to activate the amyloid, and that creates the disease. That doesn't seem to be holding water either. So again, we're beginning to think, maybe we've got it wrong. We can jump back a few hundred years. I'll just give you an example. In the 18th century, the British Navy is seeing huge losses in shipwrecks. We're just losing ship after ship after ship. And so they decided we've got to create a contest to see if we can come up with a solution for this. So they announced that there would be a 10,000 British pound prize for someone who could invent a device which would lead to better ship location and then consequently decrease the number of shipwrecks. So, I don't know if I got sailors in the room. Everyone assumed it was going to be some sort of astronomical device, the stars their latitude from sunrise and their longitude, they knew where they were. And that's who won the prize. So you may hear something dramatic like that in the dementia research world in the upcoming time. I've got to finish. So yeah, sleep, we have begun to realize, is far more important than historically we gave it credit for. You know, it used to be, he can get by on 3 hours of sleep, he's great. The romantic poets, you know, they would go on and on about, I cannot sleep for love of thee. It was made out to be good if you didn't sleep much. And we're realizing, no, you need to sleep. So one of the theories, and again, I don't think it's going anywhere, is that during sleep, we somehow get amyloid out of the brain. That's a theory. In which case, then we should make people with dementia sleep a lot. I don't think we're going to get anyway with that theory. Can I finish just with those 5 people? So again, if you recall, I talked about 5 retired university professors that you came up here. So 5 of them, they're all getting dementia. So either we have a huge number of retired professors that I'm not aware of, and this small percentage that fits the statistics are the ones getting dementia, or do professors have a higher incidence of dementia? Why is this happening? I looked at this Kunz-Holman project study. It's a neat little study out of Sweden. So the first version of it, 2009, it just showed that the kids who were tested at age 9, 10, if they were doing well at school, they had a lower incidence of dementia. So that's where this cognitive reserve theory came about. That a well-educated brain, less incidence of dementia. They revisited this in 2016, and they realized that people who may not have shown to be doing that well at school at 8, 9, 10, but if they got into work that challenged their brain, they too had a lower incidence of dementia. So that was really reassuring to see. This is that cognitive reserve hypothesis, and a lot of people don't like using the term reserve here, so they're switching it over, and you'll hear about cognitive resilience. But the idea is that education takes your brain up to the green levels. You've got further to drop before you see dementia, whereas people whose brain hasn't been challenged as much are just functioning at a lower level, and therefore very quickly get into dementia. So our professors, so we follow these people along, and to try and explain why it was happening to them. One of the fellows, he retired, he just sat at home and did nothing. So that was, I think he lost all stimulation to the brain. 2 of them, we discovered, were pretty heavy drinkers, so they had taken a heavy toll. A 4th had very complex medical issues, a lot of them related to their heart, so the vascular component of dementia. And the 5th one just got the disease. So that's how we reviewed those people. But to finish off, cognitive resilience, coming back to the idea that, it's not just what you did at school, it's the continuous deposits you put into the bank for your brain, the constant stimulation, keep doing lots of activities, what you hear about, pursuing music, learning a second language, all of that's valuable. Yes?
Are you seeing any significant contribution from concussion?
Well, yes. There's a tremendous amount of research now being directed into those brains. So we may indeed learn something from that kind of information they're able to pull out from the damaged brain. So far, it doesn't look like, because so-and-so had a concussion when they were a junior B hockey player or a high school rugby player, 1 or 2 incidents of concussion, I don't think I have to worry too much about. It's the repeated brain injury. So you picture those young
said speaking, and she also has provided a bunch of handouts, which we can perhaps give out after her chat, and then we have another refreshment break before we follow up the session with two following speakers.
So good morning, everyone, and thank you for having me. I guess I better go over here so you can hear me. Not quite as loud as Emily, but I do have the tendency to speak too fast. That's one of my response behaviors if you tie my hands behind my back. Anyways, welcome. I won't go over too many of the stats because a lot of it has been covered with Sandra and Emily as well. But as we know, it's increasing the dementia. But one of the stats I do want you to know is that 30% of home care clients with dementia actually exhibit some behavioral symptoms. And because of those behavioral symptoms, that can cause some challenges within the community. And so we need to be aware of that and help to plan to help those clients as they go on their journey. And 65% of long-term care residents have dementia or mental health issues. So that's a significant amount regarding in a long-term care setting. So we want to make sure that they're getting the support that they require and the education as well. 17% of long-term care residents are restrained. This is changing drastically all the time, which is wonderful news, right? Because we are going to that least restraint across the board, hospitals as well, you know, community, retirement homes. You know, whereas when I started years and years ago, yeah, it was quite common. Just put them in a restraint if they were, you know, wandering everywhere or do whatever, or they're out of control, just restrain them. Or now we're getting to understand that meaning behind that behavior. What can we do to help with that? And using alternatives to really reduce that. Because as you know, if you were restrained, that would cause even more mental distress as well. And of course, more behaviors. 34% of nurses in hospitals and long-term care in Canada reported physical assault over the past year, which is a significant amount. We just had education yesterday, and that was, you know, talked about again. How we kind of normalize it sometimes as nurses or healthcare providers. Acute care hospitals in Ontario reported the ALC patients occupied 17% of the ALC beds. And I know in Grave County, you'll hear that that's a lot higher here as well, due to the infrastructure and of course the elders that we're having in the community requiring that extra level of care. So there's that crunch, you know, where do the clients go? Maybe it's not safe to be in the community with the resources that are available, but yet there's not enough beds in the long-term care sector as well. So there's that challenge. So how do we as a community try to address those issues? And a lot of partnerships have been really created in a number of years lately, and to look at that and how can we all work together and help that client on that journey with family. As I just mentioned, the Gravers hospitals can range as high as 40% of ALC patients. And that's through the 5 hospitals, actually the 10 hospitals, but you know, that's pretty significant when you think of the clients and you're wanting a bed.
Are all ALC patients, I mean, they're waiting for,
They're looking for other placement. Yeah, lots of times it's long-term care. Sometimes it could be just the retirement home, but it's not that they're not going back home. So they're going to somewhere, and there's just no beds as well. So it could be stroke, you know, they're needing to, you know, even I don't know the data on convalescent care units and stuff as well, but it can be retirement home as well, not just long-term care beds. We already talked about the Hopkins statistics. And of course, 22,000, as we said, over 65 are living in Grey County. And older adults make 24% of Grey County's population, where the provincial, as Emily and Sandra alluded to, is 16.7%. And I did get that from the British. Emily. These are just some visuals of the same kind of statistics. Just I like having visuals sometimes just to show that bar as well. And what does it look like? And for the 85 and over, you know, significant amount as well. 2.2 is the provincial average, and 2.7 in Bruce, and 3.2 in Grey. So over 85, and as Dr. Mulroy mentioned, a lot of our clients, you know, we do our 75. We do have a lot that are younger as well, but you know, definitely, and even I think when we case conference and they talk about our team, we're seeing a lot of 90-year-olds, 95, 100-year-olds, and it's just amazing, right? And as they age as well. And some of the clients that are 100 are far more healthier than the ones that are younger as well. And then that's just the other visual, and Emily already had that one up as well, and just again showing that age difference between 65, 84, and 85 plus. So Behavioral Supports Ontario, and that's who I'm with, is a provincial initiative. And in
leveraging off of resources that were already in place. In Grey Bruce, we did not have a resource at all for the older adults with these challenging behaviors. So it's a new thing for Grey Bruce. But in the Southwest Lynn, and I'll talk a little bit more about that, there's different ones that have enhanced services. So people ask, well, what's a responsive behavior? You know, what classifies you getting to see this resident or this client? It can include anything verbal, physical, or sexual aggression, resisting help with personal hygiene, medications, wandering, agitation, and others. And not all of these behaviors actually are responsive behaviors. When it becomes a responsive behavior, it's more related to, is it a challenge maybe or distressing to the client themselves, maybe to the care provider, or maybe it's a concern in the community. As Sandra said, they're going into the grocery store or whatever, they're pocketing something, they're not really aware of it. You know, how do we manage that and help educate and to minimize the risk, you know, potential risk to that client? Because some other person can come up to them, be quite upset, be in their face, and then of course the fight is on, and the one that has the dementia that didn't really realize what they were doing, or the mental health issue, will be accosted, and then something happens, and then they're hospitalized, and that journey is just not there. So making that age-friendly community, being more aware of some of the concern. And so, you know, sometimes it's the accusing, right? They're accusing, well, my neighbor is doing this, they're causing me problems, they're doing that, and you know, it's causing a lot of more challenges for them. So in the Southwest Lynn, each region has an enhanced psychogeriatric resource consultant, which is like one of me in each of the regions. So one in Grey Bruce, one in Huron and Perth, one in Elgin, one in Oxford, and one in London Middlesex. And so they each support a mobile team. And so, which is really great because some of those communities already had mental health services for the geriatrics, but in our area we did not. And so we're still identifying those gaps with the seniors, and so we're trying to address them as best we can. And so we sit at a number of tables trying to really engage. And again, it's talking about what we talked about earlier, breaking down those silos and really collaborating together and working all together. So we kind of, the framework that the Behaviour Supports Ontario goes on is that three-pillar framework: the system, coordination, and management, integrated service delivery, intersectoral, and interdisciplinary. And I have to say, even in the 7 years that we've been initiated, it's just wonderful to see that collaboration and breaking down those barriers, working together, getting people to know what services are available, and not every door is the right door, and I'll talk a little bit more about that as well. And of course, building that knowledgeable care team and capacity building. And that's not just within services like paid professional services. This is within the community as well. So our value statement is, I'm a unique individual who wants to live fully with meaning and dignity through my life journey. And we always keep that in our forefront. We want, you know, how can we make this journey for this older adult when they're encountering some of these difficulties? You know, we want that quality care and that quality of life as well. And I do get the pleasure as well to support Dr. Mulray's geriatric clinics. And you know, that's our whole goal always, is to what's that quality of life for that client and what can we do to improve it. And just sometimes those small changes make huge differences. And again, we're not focusing on new resources, but how can we all work together and realign to better service that. And in the Southwest Lynn, we're also going to go to more of a senior strategy, and more information will come out shortly with that. So again, building upon aligning all those resources together to help those clients on the journey. So what is Behaviour Supports objectives? Well, we want to reduce those transfers from long-term care to the acute care or specialized unit for behaviors, right? We want to make sure we can kind of provide the care for the clients where they are, as long as it's safe, because for somebody going into a busy emerge department, they have dementia, they have all those challenges. Can you imagine how much more frightening it is? And then of course, then you're seeing restraint use maybe because they're trying to elope or whatever, they're fearful, you know, they don't know what you're trying to do to them. We want to delay the need for more intensive services, reducing admissions and risk of alternative care. You know, intervening early, you know, what can we do earlier before it hits a risk, before it hits that high risk where they're ending up in hospital when there's something else we could have done prior. Again, reducing length of persons in hospital who we discharge with behavioral resources. So of course we can help with those transitional support long-term care home actually has BSO embedded funding for their staff as well, so that's just another layer within our Southwest LHIN. Each LHIN, the model of BSO is a little bit differently on how they perform it, but we're very similar to Waterloo Wellington, where they have the embedded model in long-term care, but I think that that's starting to switch because Ontario is realizing that we can get some more education and more embedded members within the long-term care, and it improves that journey for the client. And again, just increasing their skills. We really want to make sure that we're patient-centered, right? Because that's the whole goal. We can't make decisions without the caregivers and the clients. So what is their goal and what does their quality of life look like? So, respecting that their goals, this might be not something that my goal would be as a professional, but that's their goal. So how can I help them meet that? We want to partner with those driving the care decisions as well. And really building those relationships between the staff and care providers, I think is really important, and helping educate, why is that behavior happening? What's the meaning behind it? So why are they taking that item? They just didn't remember to do that task. They didn't know to go stop at that thing. Maybe why did they come out in the bathroom with their pants down? They just forgot that task to pull it up. They're not doing it on purpose. There's just a step in part of why they might be behaving that way. Or like Dr. Mulroy said, they're talking nastily about somebody else in the thing. So that's why, that education and that community awareness. I know some of the cards, especially with some of the challenges of behaviors, they might just go join you at your table and start eating your food. And you'll be thinking, what's happening? But, the family member might be like, at least they're still taking them out, but they'll give you maybe a card to help you understand why they're behaving that way. So just building that awareness. I know we had a case with a gentleman, he'd go to the park and people were thinking he was like sexually inappropriate with the children. It wasn't that at all. It's just that he lost some of that social skills. And so, of course, he's just there making conversation or whatever, but it was not malintention. So making those relationships with police officers and that community to understand, and that went a long way versus them being hauled to jail, being in the jail system, and that's really not the right place for the client. As I said, it was a significant commitment that's been put across all the 14 LHINs, and that's continuing to grow, and of course we'll hear more probably after the election. So the geriatric behavior team is what we call ourselves here in Grey Bruce. We are a high-risk urgent response mobile team. We're not a crisis team. But we want to be involved a lot earlier, but when it's starting to become a bit of a challenge. We have a quick 2-hour response to the referral. This does not mean we don't go and see them within 2 hours. But if you call us, we're going to respond within 2 hours to call you back as well. We conduct a variety of assessments. We support the clients and caregivers wherever they reside. So we support all the 10 homes, all the 19 long-term care homes, the multiple retirement homes, and all the way up to Tobermory, all the way up to Ripley, like everywhere we're hitting all of those areas. So of course geography, as Emily said, is a challenge, and of course we're a small team, so how do we lend to that as well? We provide intensive short-term case management, so we're not involved for the long term, we're just short-term. But we will usually, after we get a referral, our goal is to see the client in 2 to 3 days, which I think is pretty significant, and we're still able to meet that demand mostly. We will have to sometimes triage that and see who's more at risk, and sometimes it might be the same day because it's like, oh well, they really need something, we're going to have to try and mobilize it. We do work 7 days a week, 8 a.m. to 8 p.m., so we're available quite a lot to help manage that. Oh, I didn't take out my change slide there. So we work closely with long-term care staff, providing the education and support tailored to their staff needs. I work a lot with Sandra Hong as well, providing that community education wherever the needs arise. We really want to, again, reduce the emergency departments. We collaborate a lot with the adult day programs, the Alzheimer's Society, the LHIN Home Care, supportive housing, VON, mental health, of course. The list is exhausting, and addictions, right? Because we are mental health and addictions as well with responsive behaviors. And then, again, focusing on the client, ensuring that they're helping help navigate the system, because the system of care is pretty complicated. And as an older adult, you have geography, you're in different geographies, you don't maybe know what resources are available. So how can, so if they call us or somebody calls us, we're going to help try and navigate that for you. I'm not going to send, well, just call this number. Maybe I'll make that phone call, or I'll find that number, even if it's a different area. I'll maybe make that pre-phone call to help them navigate that system. Because we really want to make sure that, you know, they're getting the help that they need if they're reaching out to somebody, so that there's no wrong door to care as well. Again, the capacity building, right? We provide PIECES education, GPA You First to the area. Sandra brings the You First. Soon we're going to be bringing mental health first aid for seniors. And the EPRCs in Southwest Lynn, we're the second group in all of Canada that have had that training. So some of you might have heard the mental health first aid for others. You hear teachers taking it, different areas, hospital, whatever. Mental health first aid is, for seniors, we're focusing a little bit about more dementia, depression, delirium, as well as the mental health issues. And it's not about somebody being an expert on having to treat that person, but it's to be aware. So if I'm in a community group with a bunch of older adults and I'm an older adult, that, and if I notice that somebody's maybe being a little bit off, or maybe they're having some dementia symptoms or some depression or some delirium, or I might be able to help have a conversation with them to get them to the right resources to help them identify that. Because sometimes, you know, you're not aware, that's part of the illness of dementia. You're just not aware of maybe the challenges that you're occurring as well. Or that my neighbor's not going to cards anymore. She's not coming out of her room anymore. She doesn't want to come. I keep calling on her. I'm not happening. So what's happening? So that training will be coming out soon. And I'll make sure we share it with the community. It is a 2-day training. So we're looking at different options on how to roll it out. Because 2 full days is a lot. But could we do 4 days, like half days as well? So finding out. And again, as I said, we're consultative versus case management. So when we do see a client, we will actually sit down with Dr. Mulroy, and we also have linked with a geriatric neuropsychiatrist based out of London, and he does come 3 times a year as well in person. And we provide that recommendations to those family doctors to help them de-prescribe, but of course those non-pharmacological interventions, you know, what can be done, those environmental challenges as well. So we are a new service, we're working with our long-term care, and again, trying to identify, you know, you talk about the dual diagnosis clients as well, so we don't overly see the dual diagnosis clients with just behaviors, but if they do have a dementia, we are involved with them, and we work closely with the community living in that group as well to help manage any behaviors as well. Clients can self-direct call, there's no referral form needed. Currently though, we do have referral forms for paid professionals. And sometimes we will engage with the primary care if the paid professionals or the family have referred to us, just so they're aware that there was a referral made, because all of a sudden if they're getting recommendations, they'll be saying, well, why? I didn't even know they had this issue. So we want to make sure we engage with that primary care, because if there is any pharmacological interventions, they'd be the ones to order it, or any other testing that might be required. We'll continue to evaluate our service and processes, and as we talked about, having a caregiver always is part of that process, because their lens helps us navigate that system and identify those gaps as well. We use a lot of OTN, Ontario Telemedicine Technology, but that's even getting greater, that I could send a link to the home and have maybe my physician see them and their home by using my computer. So they don't have to go to the hospital anymore to use the OTN system. So it's called personal video conferencing. Or I can send a guest link so family can join in on that appointment as well. So really using our technology to embrace that inclusiveness. Because in family, sometimes they're very far, they want to be involved. So how can I help them be involved as well? So it's kind of like a secured Skype is what it is. This guideline for geriatric assessment, it's a little bit old. I can't have all the memory clinics in it anymore, but when we did do it in 2012 or whatever, there was just these kind of memory clinics, but that's expanded even more so. And it's just a quick little guideline to say, where do you go for help? As well as, you know, it's on 211 and Helpline as well, but it's just a nice little snapshot and what services are provided as well. It will be updated after we do the senior strategy. I think we'll look at updating the map a little bit later. And then I just included in the handout our urgency decision tree. Just when is it red? Who do you call when it's already red? And what does red look like? And then of course the yellow, that caution zone, urgent, moderate risk, so that, that's kind of us. But, and the early interventions, it still can be us as well, but it also can be all the services on the bottom. Do they need addictions, community mental health, the mobile team, Lynn home care, primary care, First Alzheimer's Society, and of course the helpline. So just kind of giving a little visual snapshot for people to help identify. And this is just the pathway of what a community referral would look like. So, what would our process be? If we get the call and it's a crisis, then what would we do? We would help link you to the crisis team, maybe that education with that physician. What can we do to help them? Or help call police? Like sometimes we've gone to homes and we've called police ourselves, and we did there and follow that client with a journey just because of the safety risk as well. But we want to get it before it hits that, unfortunately. But sometimes, being in rural, you not know. So we have to also be cautious of the weapons as well in the community. They're rural, do they have access and different things. So you have another lens of safety as well, being in a rural community. And I've included that in the handout as well. And again, we're 7 days a week, 8 a.m. to 8 a.m. And there's our contact information if you require more information. Okay. Told you I talked fast. Yes?
You mentioned the election.
Yeah.
Next week, there's going to be one, and Premier Lynn has promised, or had promised, that there will be so many more long-term care beds in this province by a certain time period. Will we have to start re-lobbying next week after, depending what happens? Or
Yeah.
do you have any sense as to what they need?
My concern is we do need more long-term care beds. However, currently we need human resources to staff them. We're already staffing shortage within the current resources right now. So you can promise all the beds you want, but if we don't have the staff to fill it, how is it safe? So there's that balance. So I think there's more conversation that needs to come in. And I know the long-term care OLTCA, I think, is lobbying as well to the government to say, this is an issue regardless. We need those human resource strategy, and how are we going to engage that? And then, of course, being in rural, and as somebody alluded to, you're taking away some of those smaller pockets of people. So they're moving maybe to the centers, so then they're not going to be there to be employed because they're going to be moving out. But yet there's still residents that need to be cared for. So yeah, it's pretty complex. It's like, yeah, we do require that because you see the ALC, there's a bit of a crunch. But the human resources, to me, what I see in the community is my biggest issue right now. And because the acuity of the clients are higher, like retirement homes are managing clients that they wouldn't have managed 7 years ago. The long-term care, the acuity is increased greatly due to the more challenging, the mental health clients as well, and providing that education to help respond to that thing. And of course, the developmental disability section, acquired brain injury. So all of those complexities in the long-term care sector require that knowledge, but they also require that human resources to care for them safely.
For the land use planners in the room, do you have any comment on outside or external environmental factors that have the most influence on what you're talking about?
Like for the bill. Well, I think it's kind of like what Sandra said, like just being aware of when we go into different areas, families will say, that colors are too off. The accessibility, I hear all the time, the accessibility just to get services within their community, how to access, I don't know, I'm not sure how to answer. There's so many things.
It could also be noise contributing factor. So, for instance, with the downtown at one time, they used to have the cuckoo, and I don't know, some other bird was chirping too. So for some, yeah, right. For something at the crosswalks, for that noise and activity, the level of vehicles going by, the idea that if the individual's behavior is like, you know, sitting in a restaurant, they get up, leave your table, and go sit at somebody else's table, the family member can slip a card. You know, this is the reason behind this individual's behavior. They have a condition. So there's more understanding around that. And I also wanted to give you a story in how this was used in kind of a different circumstance. So a care partner is going shoe shopping, or just shopping in general. And she's had quite an agonizing morning with her loved one. So she's just getting out of the house and going for a break. She gets into the shoe store and she breaks down. Starts crying. Well, the sales associate doesn't know what to do with her. So she just pulls out the card. And then the sales associate says, I understand. So, you know, this is a subtle way of bringing about awareness. And by sharing the card. So I thank you for bringing that up.
Yeah, thanks, Charlotte. We have some more refreshments, so if everyone wants to stretch your legs and grab some snacks and food, and we'll reconvene at 12:25, or we can push that for a couple more minutes if everyone needs a few more minutes to take some time. Thank you.
So our next two speakers both have planning degrees, not to in any way disparage our earlier speakers, but at these planning events we tend to like to hear planners talking to other planners. So we're really excited that we had non-planners here as well today. But that being said, we have some great speakers next. First up is Chris Koala from the City of Peterborough, and he's here to talk to us about some of the initiatives that that Peterborough has done to become age-friendly in this regard that don't relate just to planning, but municipal services in general. So welcome, Chris.
Thank you. I don't think I've ever been referred to as sort of the token planner. It's a little different. Working in social services, I'm usually the token male in the room. Thank you for having me here today. I work for the City of Peterborough in the Social Services Division. I'm the Community Development Program Manager for the city, and I have the Seniors Portfolio. The way it works in our social historic background, that Peterborough was identified through this poll to be a very good place to be if you were a senior when you're looking at transit, housing, pedestrian and trail availability and our healthcare system. So I'm going to touch on some of these just as providing a little bit more background on where, some of the things in Peterborough that relate quite closely that support our aging population. So on the healthcare side, we have a brand new regional health center. We've had expanded healthcare clinics. Right now, unfortunately, we've had a couple of family doctors retired, mine included, but I'm very happy that he found someone to take over his practice, but we've had a couple of doctors that haven't done that, so we're actually back in physician recruitment mode. On the recreation, leisure, and trails, we have 3 activity centers that are dedicated to seniors' activities. We have 3 fitness centers with seniors programs, and we're constantly expanding our trail and active transportation network, both in the city and in the county. For transit, all of our buses lower. We have handy van services that provide door-to-door, and we've just created this year a community bus, which is a fixed route, but it's only in the south end of town right now, and next year we're expanding into the north end of town, but it hits spots that are popular for an aging population, so it doesn't follow the same route as transit. It's totally independent, but it goes to places where seniors frequent. And we were also successful in the recent funding from the province for community transportation, which I understand Grey County was successful in that as well. So seniors portfolio that I mentioned earlier, that was only meant to be a little part of my job. It's expanded to be more than half of it. And rural transit, as you mentioned, benefit more than just an aging population. It's going to benefit a lot of people. So that transportation grant is really important. I'm very excited. A lot of people are excited about that because we've talked about rural transportation for decades in Peterborough County. And it's a small area that we're covering on that, but we're very excited about that. With housing, we do have quite a diverse supply, not enough supply as most of us probably attest to, but we have the supportive housing, we have the rent geared to income housing, we have long-term care facilities, and we have a growing number of retirement residents. Unfortunately, the increase in many of the retirement residents are on the higher end side, which is I think a trend that's happening everywhere. So we have a couple of developers that really geared for higher income seniors, and these buildings are popping up with high frequency. For local services, I grabbed as many logos as I could. This is my graphic design capabilities right here. That one of the things that makes Peterborough interesting and special, and it's lent itself, certainly in the age-friendly planning that we've been doing, was around all the organizations, agencies, institutions, businesses that were interested in contributing or have been working together in one way or another to advance the priorities of an aging population. So this kind of created a solid foundation for the age-friendly plan. surveys, online surveys or hard copy surveys were done. We had participants in focus group sessions, people that we targeted, certainly older adults, caregivers, service providers, respondents. We were happy, you know, almost a 50-50 split between the city and the county. That worked out pretty well. One of the challenges we had, as you can imagine, reaching isolated seniors. We ended up, the way we tried to solve that problem, we sat in a dialysis unit at the hospital for a couple of days and conducted our 45-minute survey, 100 and some odd questions with people in dialysis. So that was one of our strategies for trying to get those that otherwise wouldn't capture. And this is only part of the story, that corporate support for staff is not reflected partnerships has always been with United Way. They got a donation through an estate of around $375,000, and they said put it towards seniors issues. And United Way decided to invest in the implementation of our plan. We just passed it in 2007. All municipalities, both First Nations, have adopted it. So it doesn't happen very often. $375,000 to implement our plan. We weren't ready for that, and we've been working through how we were going to spend that and how we're going to decide what we were going to spend it on, because the committee was new, and that it was a good problem to have. I'm sure everybody here would love to have $375,000 to implement age-friendly activities. So basic needs group is developing a housing and health needs study. We're looking at what kind of options there are, health services for aging in place, deep analysis of what our aging population looks like now and what's going to look like in the future, specifically looking at certainly those housing and health related issues, and preparing for housing needs and opportunities. We want to be in a position. There is going to be housing money coming from the federal government, maybe the provincial government, it's hard to tell anymore. But right now, the city and the county are not prepared to say we want to build supportive housing for seniors. We certainly have low-income housing ready to go, shovel ready, but we want to be in a position using this study to say this is ready to go as well. So when there is funding, we can advocate for building housing. Our Staying Mobile working group, like I mentioned, we got $1.5 million through the rural transportation grant, and which is great. And it's going to link one of our First Nations, Kurluk First Nation, Selwyn Township, and with the city in our transit system. What's exciting for me, both for age-friendly work, but then my other work, my community development hat on, is that we built in a feasibility study about expanding that to the rest of the county. And that study will take place in the third year. We also have a program for walkability assessments that we're building in. We're going to train staff in each of the townships and important representatives in the city on doing those walkability assessments. We're going to try to tie them to development. So we're going to be looking at the capital plans of all the municipalities and projecting out 2-3 years and offering these walkability assessments where we know that the municipality is going to be redeveloping a sidewalk or a road or a trail or a park, and try to do that upstream and give them advice on what would make that infrastructure better for an aging population. The Building Relationships working group, we're working to implement an age-friendly business program. The grants, the provincial grants, we got one as well, and we already had our plan being funded, so we applied to do our age-friendly business program, which we're almost ready to well, we already implement. We're just waiting for a couple of things to fall in line. We're going to start working on an elder abuse strategy with our partners to see where age-friendly Peterborough fits in, because we have a very strong Elder Abuse Ontario chapter, and we just want to see what role we can play. And we did some pride and positivity. We got a little grant to do some training around LGBTQ residents in long-term care and seniors homes, and doing some awareness training of staff in those facilities. The last one, our learning sorry, but this one's quite busy. We're part of that United Way funding. We're doing a recreation and leisure study. Those 3 senior activity centers that I mentioned, they have dwindled in membership. Their membership is getting older and older. Younger members, the younger seniors are not coming in. So we're going to do a pretty comprehensive exhibitors, businesses, not-for-profits, talking about what they do. We get 1,000 people attending at our sport and wellness center in Peterborough that come to that show, which is in a couple of weeks. And then our summit on aging this year, quite fortuitous, it's on dementia. And it's a one-day kind of conference where we bring in speakers and run workshops through the day. Just a couple of little posters for those two events. Like I said, I got them here, and I'd be happy to welcome people from Grey County if they wanted to attend. And that's it. Happy to answer any questions you may have. Yes.
Did you say that the Peterborough Council on Aging isn't going anymore, or has it just been redefined in those working groups?
Yeah, we're now the age-friendly Peterborough, and that advisory committee is our decision-making group.
Is the advisory committee made up of people from all those four working groups now?
Chairs sit on that, and then we have politicians from each city, county, and both First Nations, and then we have community members, community seats, one for each of those communities as well. So that's the working group chairs, report up, and they're the link back to the workers, people that are doing the activities. Yes?
I'm just wondering, Chris, are you finding there's a need or preparing for a need to adapt your age-friendly communities plan to people from different ethnic backgrounds?
Our new Canadian Center hasn't been overly involved with our plan, and I go on a limb, I believe there may be an action or two in there related to the different ethnic groups. Peterborough, up until the influx of Syrian refugees coming in, Peterborough has very low representation of minorities. That's changing, certainly. And as any plan, I'm ready right now to put a second version of this thing, which just passed last year. And we'll have new activities. But our new Canadian Center has been pretty busy doing other things. And I recognize
Big stuff.
it is, but it's not. For sure.
Being prepared to
Certainly.
all Boy Scouts.
Yeah, no, I agree with you.
Thank you.
Yes.
Can you get the plan online?
Yep.
Awesome.
Actually, yes, you can go to that. We have a Peterborough Council on Aging, this is my problem. I just got that site up. But yes, information about the summit and the showcase are on that website, as well as copies of the plan. All right, thank you very much.
Feel free to stretch. I know it's a lot.
Yeah, if anyone wants to grab a quick snack as well. So the last presenter is Sam Biglieri. She's an old classmate and friend of mine, and she's currently studying her PhD at the University of Waterloo. I know that we have gone a bit over the allotted time for the agenda, so this is kind of eating into the panel discussion time. We do have the room and space booked for up until 2:30, so if those of you are willing to stick around and have a discussion, by all means, I'm sure there'll be lots of questions, but those that need to sneak out, by all means, thank you for coming.
Thanks, Steph. And thank you all for staying to the end. It's greatly appreciated. So I think, well, this is not going to balance. All right. I always think before I start a presentation, it's good to know where somebody comes from. I started with genetics. I'm the child of a public health nurse and an urban planner. And so I think it sort of implements Tony Biglieri is my father, in case anyone wants to know. All right. So I'm an academic, as Steph said, but I'm also a practicing planner. I use my knowledge in a consultancy Alzheimer's disease that I began to realize how much of an impact the places we live in have on our quality of life. So you see, I grew up in a place called the Beaches in Toronto. And it's what our good friend Jane Jacobs might call the perfect fine-grained neighborhood where you can walk to everything, you can walk to the beach, transit was easy, the beach was a quarter mile from my front door. Now, my nanny and papa, however, lived in the house my mom had grown up in. It was the end of a cul-de-sac in Oakville, Ontario, what you may call a suburban-style municipality. And after my papa died, my grandmother, my nanny, got Alzheimer's disease, and we watched as this place that was so full of so many important memories, and I'll try not to cry because every time I talk about it, I do. I watched as this amazing place became like a prison for her. So she lost the ability to drive, she was too scared to take transit, and she certainly could not walk anywhere. And it really impacted her relationships with others. It impacted her social well-being and her ability to feel independent. So my mission, the reason why I'm doing a PhD in the first place, is to figure out, just like people who use wheelchairs need ramps, what are those cognitive ramps in our built environment for people living with dementia? Just a brief going over what I'm going to talk about today, setting the context, why does the neighborhood matter, talk to you about a paper I published recently in Planning, Practice, and Research, and did a summary of in Plan Canada. And then current stuff I'm doing, and I'm hoping you come away with learning a new consultation tool. So I was set up really well by my fellow panelists, so I don't have to tell you what dementia is, which is great. So I'll just cut right to the chase. Many people assume that people living with dementia live in care homes. This isn't the case. Estimates in Canada estimate 2/3 of people living with dementia live at home. In the UK, this number is as high as 80% of people. And yet, the vast majority of research is focused only on congregate living settings. Many of you may have heard of a place called Hoogeveen in the Netherlands, which is that village for people living with dementia, and it's enclosed so that people can feel safe, but they can also go to the grocery store, ride their bike, and it's fantastic, but it's still segregated. So I remember I went to my supervisor in my master's and I was like, you know what, I want to bring this model to Canada. And he said, you know what, that's an architecture project because it's a controlled setting, and I'm an urban planner. So I'm interested in the neighborhood where things can go wrong, pretty much. So, anyway, studies have also shown, as we've talked about today, people want to age in community, it's better for their health. And this work builds on the work that's done in terms of dementia-friendly communities, which is really about changing how we interact with people living with dementia. But for me, it doesn't answer my question of how do we change that physical environment. So why does the neighborhood matter? This is a graph from a study that was done in Israel. They put GPS trackers on people living with mild dementia and people, so-called healthy people, over the age of 65. They found on average the so-called healthy people traveled about 1.5 kilometers, a mile from their home, and people with the mild dementia 400 meters or a quarter mile. So that really tells us how important that neighborhood next to us is. There's also research, Dr. Mulroy talked about this, the idea of cognitive reserve or resilience applied to the neighborhood. So my whole thing was, would it have been different if my nanny had lived in the Beaches than if she had lived in Oakville? A neighborhood is also a source of identity and inclusion, but it can also become frightening. And we also know that certain kinds of neighborhoods, like was mentioned before, can support better physical activity, more social interaction. So the question is, where do we start? So for me, a good place to start is with people living with dementia who are advocates for themselves. And this is an organization called Dementia Alliance International. And their version of a dementia-inclusive world is a world where a person with dementia continues to feel fully valued and included, nothing about us without us. And they're actually really inspired by disability rights advocates. So people using their personal stories to demand their human rights, pretty much. So did you know we used to ask doctors about how people in wheelchairs felt about getting around in space? Nuts, right? And we have to apply this to people with dementia. We have to ask them. So, and I also think that if we can't ask them, we're not trying creative enough approaches. So we have to keep working on that. And it also goes further to say that people with dementia are citizens of the society they live in. They deserve to access the neighborhood just like the rest of us. So what's being done? The truth is, there's not a lot out there. There are maybe 15 studies on people with dementia and the built environment. None of them are based in North America. The most seminal study was done in the United Kingdom, and I will tell you a little bit about that right now. But before we go on, this is a person who tweeted at me after reading about one of my projects I'm going to tell you about. And this is Roger, and you can read it for yourself, but I have this printed on my desk every day a day gets bad. So just to remember what I'm doing and why I'm doing it. So, the Burton and Mitchell study, whoa, go back. Okay, sorry, I could, okay, yes, please read it, then I don't have to read it out loud. Good? Awesome. Sorry, I do talk too fast. So, Burton and Mitchell, a town planner and an architect, both working in universities in the United Kingdom. They did walking interviews, which is just as simple as it sounds. You go on a walk with somebody, they take you through their neighborhood, and you ask them questions, and someone goes along and plots where you're going, or you can use GPS, whatever it may be. And they found that PLWD preferred less socially demanding places. They traveled to one place per trip, and feelings of things like anxiety, confusion, and fear of embarrassment were common feelings. But that being said, Burton and Mitchell found there were so many benefits to accessing the neighborhood for those individuals. Things like a sense of freedom and autonomy, dignity, sense of worth, physical activity, psychological well-being, and social interaction. So this is where the planners are gonna be like, oh my God, recommendations. Okay, so, they came up with 17 recommendations, so I'm standing here so I can see the thing. I've grouped them into sort of 3 thematic categories. So the first one you'll see is things like walkability and land use strategies. So things like having mixed use nodes, small blocks in an irregular grid pattern, classic things that planners know about building walkable communities. The bottom bubble there, urban design for comfort and safety. These are things like bus shelters that actually cover you entirely and protect you from the elements, accessible public toilets, benches with armrests and backs so that you can actually push yourself out of a chair, which is really important. You'll also see things like the classic marked level changes like we talked about before. The thing that is different though from when I think about age-friendly stuff is the wayfinding piece. So how many people have ever gotten lost in a new subdivision? Because everything looks the same, right? And we don't force a developer to build a couple different kinds of style of house. And we build all the roads exactly the same, all the junctions exactly the same. So this piece here is really trying to get at, can we make those intersections different? Can we put a planter over here? Can we put the community mailbox over here? And can we get developers to build different styles of housing? So at least one study. So that's interesting. The second way is I went through all of the town of Whitby's policies and I figured out how we would insert them in the different policies. So they range from big things like an official plan statement saying we're going to plan for everybody throughout the life course, all the way down to changing those darn engineering standards, like we were talking about this morning, to allow for things like non-slip pavement, frequent and accessible road crossings, things like that. So if you want to know more about that, I'm happy to chat. I also looked at different planning principles. I primarily used Kevin Lynch, you may have heard of. And so the pro forma. So typically, developers say they want a 15 to 20% return. That's a profitable development. You'll notice the developer is making pots of money in the base case scenario. It's getting about 45% return. That's far more than the 15 to 20. When I put in all the dementia-friendly recommendations, including like a mixed-use node, when you put in a mixed-use node in a primarily suburban municipality, costs skyrocket and it's hard for them to sell those apartments. So that's why you end up with a lower rate of return. So I added a couple of incentives, things we do all the time, a little bit of a reduction in the charges that a developer pays to build, and a little bit of a reduction in the amount of parking they had to provide. And shocker, it was back up to being profitable. So what does this tell us? It tells us that we really need more legible, comfortable, and safe suburban development. There's also this question of incentivizing or non-incentivizing. That kind of thing can be done through pro forma analysis. There's also the importance of educating the planning profession, that's why we're here today. And more research is needed in the North American context. And so that leads me to my project and my research at the University of Waterloo. So my research is called Planning Dementia Supportive Public Spaces. I work with community dwelling people with young onset dementia. So this is people who've been diagnosed before the age of 65, and they live in or around the region of Waterloo. The beauty of Waterloo is that you have downtown core, 5 minutes suburban development, 5 minutes rural. So I don't have very many participants. I have 5 so far, I'm getting more. But they all live in entirely different places. I have core, I have suburban, and I have rural people. So it's been very interesting. My participants right now range between 57 and 71. So, when I think about planning, I think about how planners can work towards justice. And so that's sort of how I've oriented my research project. So I'll tell you a little bit about them. So justice is through outcomes. So was a ramp built? Or was it not built? Justice can be through process. So who has access to the planning process in a meaningful way? Did you have an ASL interpreter at your public meeting? Were your maps easy to see, or were they 12-point font and no one could read them? And the last way is changing how we think about people who are different from us. And others have talked about this, the role that stigma and discrimination plays. We know those things impact and compound neurological issues, and it's no different for people living with dementia. I just want to tell you some words that we use. So we say things like, the general we label people with dementia as dangerous wanderers. We perpetuate the tragedy. We see them as incapable of growth post-diagnosis. We call them sufferers. I used to do that, full disclosure. We prevent them from perhaps participating in research and something that someone living with dementia calls prescribed disengagement. And people with dementia are citizens of the places we live in, and we need to work towards changing our language and changing how we think about them. So I am using over 7 different methods to get at these questions, and the reason being that I want to be prepared and adapt those methods as I move along with participants, because I'm not going to know right off the bat what to do properly. I'm learning with my participants on how best to get information with them. So I'm going to tell you about one tool that I'm using, and so it also happens to be the walking interview, an incredibly important tool, or could be an important tool for people in planning, public health, and even social services. These are being increasingly used in academic fields, and it's primarily because people are better at talking about their neighborhood when they are in their neighborhood. They get cued to things around them. Maybe they see people on the street. Maybe you get more participants that way. And this is true for everybody, not just people living with dementia. And I actually met a planner from Des Moines, Iowa, where they're doing these walking interviews in a gentrifying neighborhood to really understand how their social services could help them to continue to live in that neighborhood and different housing needs as well. So it's something being done in the municipal sector. So how do we do it? So what you'll need, usually, an audio recording device or a clipboard or a GPS tracker. I ran these on my own, so I did the audio recording in my GPS tracker. You can download a phone on your app, or I use my watch. And an optional thing is to carry a camera. And really, it's about asking them to take you on a walk that they like taking in their neighborhood. And you'll find out a lot of things as you go along, and having sort of guiding questions to be there can also help focus. I had my participants, we did a little pre-interview where they told me where they grew up and what kind of transportation they used, how long they lived in their community, and where their neighborhood in their mind existed. And then we went out on the walk. So I wanted to share some observations that I've had so far with my participants, and this is an ongoing story. So some incredible stories of what I think are kind of coping mechanisms. So one gentleman, we'll call him Mark for all intents and purposes. So I gave him the map, and he drew a box. He followed the road and he drew a box. He said, "This is my walk." I said, "Okay. Do you go any farther?" And he said, "You know what, Sam, I could go to the Canadian Tire, I could go to the Home Hardware, but I don't want to." And I said, "Okay." It's like, what I want to do is I want to create a route and make it a habit. He takes it every day with his 2 dogs, so that when he gets worse, he can still do the walk. And so, again, like this whole time, I'm like, whew, like they're just amazing things. And he lives in a neighborhood where he knows he goes out the door and he goes left, and he can turn down any one of the streets, and he gets back to an arterial, and then he comes back home. And he knows that's his loop, and that is how he knows where to go. Another gentleman took me on a big long walk, and he knew he was going towards the library when the river was on his left, and he knew he was coming home when the river was on his right. He was also someone who looked for big historical buildings, so he was a mason in the past, and so he looked for the historical buildings in this downtown in order to orient himself. I also had another lady. We were in sort of like a power center type area, and so we're like walking along, and there's a stop sign here, and you're going to cross the road. And so you and I, we see the car coming, we know there's a stop sign, so we would just walk across the street because we know the car has to come to a complete stop. But what she did, and I watched her do it, I didn't ask, I just watched her. She waited at the edge of the sidewalk. She waited for the car to come to a complete stop, looked both ways, and then crossed the street. And so this goes back to other stuff I've read about how when we cross the street, there's a lot of information coming at you. You're negotiating people coming at you, there's sound, there's visuals, and for someone with dementia, they can get overwhelmed by all those things, so they try to think of them one at a time. So that was it, literally in action, what I'd read. And in this work, we also talk a lot about the importance of familiarity and belonging and purpose. So one gentleman, they lived in an older subdivision where all the houses backed onto a park, and it was kind of this like private-ish park. And he loved it because he helped build the ice rink in the winter, and he could look out the window and watch the kids play, and that was fabulous. And it's kind of something I think you kind of discourage now we're doing in subdivisions. Another guy in his subdivision, they had walking paths in between the backyards. And so again, something not necessarily done as often anymore, but he loved it because he could chat with everybody on his way, because everyone's in their backyard. And he purposely got up to go and talk to the moms and kids on their way to school. So he did that every day. That's an interaction's important. And the last one I'll leave you with. So one gentleman takes me on a walk in an industrial park, okay? An industrial park with no sidewalks and massive trucks going by. And I said to him, I was like, so-and-so, usually people are scared of industrial parks. You know, like they're not inviting places to be. And he had told me previously that he used to work in a factory and he had gotten fired. And he said, you know what, I love coming here because I still feel like I belong. And I was like, whoa. So things we think of as planners are like, you know, this is best practice, whatever it may be entirely different from how people feel about their community. So I will leave it there. Stay tuned and happy to answer any questions. Yeah. Or if you want to do the panel now. Or... If there's questions. Okay. Yeah. Yeah.
Fellow planner in the room. I've always been somewhat interested in the amount of sign signalization and attributes we provide to the vehicle.
Oh yeah.
On a street.
Mm-hmm.
Do you think people with dementia would benefit from that level of signalization or signs from a walking perspective? I've been thinking about your lady who waited for the car to stop.
Yeah.
Whether there would be a smaller stop sign, and I also have young children, which I teach them all the time. Don't, we were just talking about that. Don't assume the car's going to stop. Wait for the car to stop.
Yeah.
Exactly. Do you think there would be any benefit in pedestrian level signage, like at that intersection, notwithstanding the fact that the woman had the right of way to go across because the car was supposed to stop at the opposite intersection, to have a pedestrian level stop sign or yield sign or something that's more pedestrian friendly for pedestrians?
Yeah. That's a good question. And I think I would hazard a guess to say yes, but then I'm also cognizant of what we talked about before of having too much noise, right? And noise can be very overwhelming. So it would be something that I think would be a really good idea to bounce off the participants and ask them about their preferences. Because I can hazard a guess, but it's probably better for me to ask them what they think, but that's really good, and I will include that in my next thing, so thank you.
No problem.
Yeah.
I only need a big credit.
Yeah, no problem, I got it. Yeah.
Mine's more of a comment than a question. I think that the adaptation of Kevin Lynch's cognitive mapping is a great adaptation. Thank you for sharing that. This is just sharing an anecdote, but when it comes to land use control and memory, someone told me anecdotally, so I don't know the name of the city, but near Venice, it's also a water-based transportation urban area, and because of the fog rolling in so densely, there's land use regulations that prevent the color changes to the house. The red house has to stay in perpetuity. The red house, because it's what the gondolas use to
not bang into
things that orient themselves with it. So I thought that was kind of related. I just wanted to share that with you.
That's cool. Thank you. I've also heard of, I don't know if it's Unionville and Markham or somewhere else, but they started putting up plaques of like what building was there before, with like photographs and stuff. And again, another anecdotal comment. A professor of mine from Ryerson was talking about how one of his friends who has dementia really appreciates having things because then he can sort of remember where he is in the downtown, which is really interesting. So yeah, totally.
I just want to make a comment. One of my other passions / Achilles heels is using plain language. So when you showed your signs with the pictures, they weren't just signs with pictures. They said, park, school, instead of sometimes we prefer to change things to the more complex words for some reason.
Yeah.
So I think it's really important also to say that when you have a sign that you say in the most plain way you can.
Yeah.
What it's for.
For sure.
Where you're pointing.
And I'm totally guilty of using too much complex language. And anyway, I have to like keep thinking about that. So thank you. Yeah. Yes.
Well, first of all, thank you for your talk. I quite enjoyed it. But this is more of an observation. In the world of medicine, one of the wonderful, somewhat serendipitous discoveries we had was people who have seizures never get depressed. Well, that led to a whole wonderful treatment plan. But in the urban planning world, do you talk about the London
England city taxi drivers?
I mean, I've read about it.
Yeah, so,
yeah.
I mean, these are the old style guys, you know,
Yeah,
they're not saying on GPS, turn left in 300 meters. These are the guys, you get in the cab, and you say, I wanna go to Harley Street, they get you there. I wanna go to 221 Baker Street, they take you to Sherlock Holmes' house. So, imaging of the brain, we know that it's the hippocampus shrinking that seems to cause people trouble with memory. The taxi drivers have these big bulging hippocampi. So being able to read maps, envisioning maps, directional cues seems to stimulate the hippocampus. So I mean, the whole idea of your neighborhood, I think, is brilliant. You know, it builds so much in for people. If they're walking, they're getting the stimulation of the people they meet, and you know, just the cueing to the hippocampus. So
yeah, totally. I totally am simpatico with you on that one for sure. And that's why there is some research now about that, like cognitive reserve, but in terms of the neighborhood you live in. And so that sort of thing as well. And then I'm also like kind of nervous for people my age who don't know where they're going and they only use a GPS. Right? And so like I make a point of like turning off the GPS and trying to figure out where the roads go, which is really hard in the region of Waterloo because roads do this. Most confusing place I've ever been in my entire life. I don't know where up is. Just saying, Waterloo. But trying to learn, like even thinking about when you go to a new place, how you form a map in your mind. So like for me, it started with, okay, I moved to this apartment, this is how I get to the university. And then this is how I get to the grocery store. And then I started to like fill in roads eventually over time. And I think that's another good exercise for us to do. And I don't know what's gonna happen to my generation who doesn't know where anything is. But we'll just rely on GPS when we get old and it'll be fun, I guess.
Signs with pictures of
Yeah. Yeah. I mean, one of my participants, he loves his smartphone. And so he uses his GPS all the time. He uses it on his bicycle. And he's really utilizing his smartphone to prepare himself. So he has all of his contacts have multiple photos of the same person at different age stages. So like his children at different ages, his friends, whatever it is, and he's attached all of their social media accounts to the contact so that he knows what's happening, which is amazing. And then he also told me that he loves to, he texts me and he likes to use emoji. And I was like, why do you like using emoji? And he was like, you know, sometimes I can't think of what the word is. And so they're very helpful. They're like, it's so cool when you ask. Okay, sorry. Yeah.
I can't resist. There are so many opportunities with technology, but we have absolutely already seen changes to children's brains with so much screen use. And I just have to say, just wait for it. And I think what we're going to see with heavy screen time use and the incidence of dementia and screen use being paired together. So sure, there are apps that help those things, but the app itself can create learned helplessness as well, and also is going to create changes in the brains of people who are using screens too much.
I'm definitely not a doctor or a neuroscientist, so I won't comment on that, but I feel you on that comment.
And thank you so much for your presentation. I love your enthusiasm. I'm wondering how you recruited your participants. Did you have partnerships with anybody?
Yeah, so without naming the groups, there are some different support groups in the region of Waterloo that I was able to be put in contact through my committee members. One of my committee members is Dr. Sheri Walden, who's quite well known in terms of recreation and arts therapy and dementia. She helped create the musical Cracked. I don't know if anyone has seen it, or a play. It's basically taking lived experiences and putting them on stage, which is fabulous. So I got a lot of it through having those committee members. The University of Waterloo has aging as a research focus. So there's a lot of resources on campus and desire to interact with people and participate. And I think the people who participated in my study have also participated in everything else. So they participate in hacks for health, they do a hackathon where they develop apps and they're the experts in the room. And so yeah, through things
neighborhood. I've lived in this neighborhood, she said, for so many decades, don't want those people. I'm sitting there going, there's a great possibility you can remain in your neighborhood because you may want to live there very soon. No, was not going to hear of it.
I'm going to invite all my panel members back. Okay. Yeah. Panel members, come back.
So we are getting into bonus time here. So just for the benefit of those that may have to leave, I do want to thank all our speakers and panelists today. So we had Jan, Sheri, Sandra, Emily, Brendan, Charlotte, Chris, and Sam, for all your wonderful insights. I think it's been a really broad discussion and lots of unique levels of expertise. I did also want to thank the people that made this event happen today, particularly Stephanie here, drew all the panelists together and organized everything. Helen and Hiba have been great at helping record the event and do the registration. So a big round of applause for all the panelists and people that and without further ado, we're into bonus time now. So you paid till 1:30 and you're getting some further time. So there you go. If anyone has a question they'd like to address to an individual panelist or to the whole panel, please feel free to do so. If no one has any questions, then I'm going to start answering questions. So or asking questions. So last call. Okay, just very briefly then, I would like to hear maybe from each of the panelists, if there's any low-hanging fruit that you think that a rural county could be looking at to start getting their feet wet in both maybe age-friendly planning, but also maybe adaptations to our built environment, whether it be infrastructure or public spaces, that we should be looking out for sort of in the near term before we finalize sort of a long-term plan. Maybe we'll start at this end now.
So I think one thing that is low-hanging fruit for many programs that we always overlook is that our high school students are required to do 50 hours of community service to get their diploma, and it is so underutilized in so many ways. And what we heard, what London heard from their age-friendly city, what Hanover heard from their feedback was older adults wanted the opportunity to share with youth what their knowledge and to learn from youth. And I think that one real low-hanging fruit there is to link them up with those students that need to do those 50 hours to graduate.
I need to think further on that type of question.
Sure.
I don't really have one that just jumps to my mind.
I think the benches for you guys were
And I'd like to talk about, we've been looking at some other websites, and a lot of the generational, putting the children coming to visit with the people in the dementia situation and how important that has been. So that is one thing that we could put a bit more pressure on, not pressure, but ways of maybe making that happen. And the other thing is we have spent a lot of time telling people to call 211, because you talk to a real person and you can get an answer. But we also realize that some people want to talk to another senior and they'll talk further. So there's a program out in Thornbury called Answers for Seniors, and they have volunteers that are basically trained to answer questions for other seniors, and they set themselves up. This is also happening in the Bayfield area where it's in the library. One afternoon a week, seniors can go in and get answers. So that's one we'd like to promote right here in OSAP.
I don't know if I need more time to think. I was just thinking about like wayfinding signage, because we're constantly updating that. You could probably do it in this building even if you wanted to, right? Yeah, you could print them off on pieces of paper if you wanted to. That would be my low-hanging fruit. And yeah, that's my low-hanging fruit.
Can I just add to that whole wayfinding thing? I wanted to give the example of a public bathroom and a story of an individual with Alzheimer's disease who's going into the public bathroom and can't figure out how to get back out of the bathroom. So a simple sign on the back of the door saying way out can really help that individual the stigma, talking about Alzheimer's disease. There's not enough people feeling comfortable about talking about the disease. And again, because I like to tell stories, I can tell you about Fred, who's in the grocery line, and he's a few customers back, and there's somebody at the cash counting out their change, and that he's having difficulty figuring out the change. But anyway, he makes this joke, oh, I'm having an Alzheimer's moment. Well, Fred was just newly diagnosed with Alzheimer's disease. So it was pretty much whacked in the face by the fact that they're making light of this situation. So he goes home and he looks up on the computer, he looks up jokes about Alzheimer's disease. There's all kinds of jokes on Alzheimer's disease. And then he looks up jokes about cancer. And you know what? There's not so many jokes on it. So, you know, for people to understand what it means to live with Alzheimer's disease and the importance of that knowledge and understanding for that person to feel safe and comfortable to go out into their community is a huge piece. So that's my little.
Here. Getting back to the washroom, local geriatrician in Peterborough who is dedicating her life to dementia and memory clinic. She recently renovated her office, expanded, and did everything she needed to make everything accessible. And what she found was her clients couldn't get out of the bathroom. Right? They had the button, they had all the locking and all the signing, but they were constantly having to basically break into the bathroom because they were getting stuck in there, because what the AODA says is accessible is not dementia accessible. And because we work together, we actually co-chaired the Council on Aging together. She called me and talked with all the planners, dragged the planners from the city in to say this is not right. So that was an interesting process. But as far as low-hanging fruit, I think in all the work that through social services, all the programs are, I think awareness, anything we can do to promote what's already going on. That, time that always happens is I didn't know about this, I didn't know about that. I know that gets to the whole communication and information and awareness parts of the age-friendly planning, but I don't think we can do enough for people to know what is in the rural communities, a place like Havelock or Norwood or even Ashley, in my neighborhoods, people don't really know what's available to them. There's a place like Katie Care, or the Legion, or the Rotary Club, or whatever it may be. So,
We don't even always know what each other are doing. Communication is huge.
And I think all the municipalities have talked about have rural components. And many of those, people talking about isolation in Oakville, try isolation in Armo, or somewhere out in that area. We're struggling as rural planners, as residents of rural area. People want to live where they've lived for 40 years or whatever, but to be out there, there's not transportation, there's not a street to have a pattern on. There's the decisions in a smaller community like a Ripley or a bigger city, this area city like Owen Sound, are smaller because there is something to work with. But for many of our residents who are out in the rural area, living alone, and families may or may not be around the corner. Most often they live on the same farm, but they all work, they all do things. So there's a point there with safety. And there's a lot of the things that we've talked about today that are just not, we don't have any tools in that box.
I'm just going to comment on that. I don't disagree with you, but I was working on the conference with Canada about mobility, and a graph that just keeps sticking change that for seniors who have income, who can afford fast, not get a break. I'm fighting that conflict with people sitting around me at work because they're not going to take transit. They don't get on early. They're just going to stay isolated with that crappy sidewalks or walking out of there.
I think the other thing that is maybe helpful to people, especially if you're working for the county or the municipality, is to find partnerships with groups. So when you're looking at things like safe sidewalks, I know that we had partnership with the City of Toronto. There was a lot of problems with falls on sidewalks in the winter. And the City of Toronto to put out something around being a safe walking pedestrian was really risky because they could be perceived as blaming the pedestrian as the victim when, you know, anyway. And so partnering with a group of people who work for fall prevention in Ontario, and we were able to make like a resource to talk about how to, you know, maneuver sidewalks safely in the winter. So finding those people that you can use to pull, you know, data and to provide resources that maybe you can't because of the hat you're wearing, I think is another helpful tip.
Any final thoughts or questions? Anne?
I asked someone earlier about how much outreach there is to businesses and commercial enterprises. Let's say a business is applying for a license or a permit or signing a contract. Could there be something on that form which says you are located in a neighborhood, a community where there is a high population of aging or people with mental health care being given, and you should be, if you want information or resources, learning resources, contact information for the kind of help that new businesses would need. Their customers are coming in from all over the neighborhood who will need special assistance. Like, was it you were talking about the fellow who comes into a store and inadvertently puts something in his pocket? So that owner of that store should have already been aware and prepared to know how to assist that person. But so new businesses might have a chance to do that if they were given information.
Yeah, that's another low line. Just, you know, getting into those businesses.
You could just walk in and talk to them and see if they, but you could put it on a permit so that when they sign the permit or the contract, they have to be made aware. So they're agreeing to be in that location and you know, maybe commit themselves to learning.
Yes, yes, absolutely.
So just to build on the using high school students, in Toronto, I'm on the Toronto Council on Aging, and so we're located in Midtown, so just north of the downtown core area. And we've been running a project where we pair an older adult with a high school student, and they go into the business and they do a little age-friendly business checklist, kind of like a secret shopper program, and they give the feedback back to the store. And also we give them training, and they get to put a sticker in their window that says they're age-friendly. And then in the region of Waterloo, through the Alzheimer's Association, they're doing the Blue Umbrella program, which is the training of businesses to be dementia-friendly, which is an amazing training thing that everyone should do. I did it up in Elmira, and it was really eye-opening things, like, and things that I use with my nanny later on. Like, you know, you open a menu and there's like hundreds of choices. The advice was, instead of saying, okay, we have 20 different kinds of drinks, you say, do you want something hot or cold? And then you sort of like go down that way, you make the choices shorter and like easier to think about. So I do that with my nanny, and it's easier for her to think about what she wants from the menu. So like simple things like that. But yeah, things we can definitely build on, for sure.
Thanks. Well, we could go on and on, but we really need to thank you guys for putting this on.
Yes.
Thank you everyone for sticking with us. For those of you that did register online, the Ontario Professional Planners Institute will be sending out a follow-up survey. You can give your thoughts, the negative, the positive, and the very last question on the survey is always, what further subject matter do you think we need to be investigating? And that's the one I'm always most interested in, and we've stolen many great ideas from the attendees of these events in the past, so we hope to steal more. Thank you very much, everybody.
Say